immunology. Immunology, lymphostructures, uh, immune systems, organs. Oh, immunology, lymphostructures, immune system, organs. Primary organs are bone marrow, immune cell production, B cell maturation, and thymus, T cell maturation. Secondary organs are spleen, lymph nodes, tonsils, Peyer's patches, allows immune cells to interact with antigen. Okay, so primary organs are what they're going to focus on mostly, and these are going to be when you get infections and stuff. So Peyer's patches are in your colon or intestine, small intestine, tonsils, lymph nodes, spleen, Uh, someone's mic is on, so I'm gonna turn that off. Uh, where was I? So primary organs, bone marrow, immune cell production, B cell maturations. That all these things happen here, and then in thymus you get T cell maturation, but not T cell production. So remember the difference. That happens here in bone marrow. Secondary organs are these. And what do? They allow immune cells to interact with antigens. So if uh, a cell with infection comes to the spleen, immune cells are gonna act on it over there. That's why when you have infection, sometimes in your around your neck, you have swollen lymph nodes because uh, your immune cells are going into action. Lymph nodes are secondary lymphoid organs that has many afferents, one or more afferents, encapsulated with trabeculae in A and B. So uh, that's your trabecula. This is your capsule. Functions are nonspecific filtration by macrophages, circulation of B and T cell, and immune response activation. So you're gonna have both cells in this organ, the lymph node. In follicle, you're gonna have B cell, and paracortex, you're gonna have T cells. So follicles are these things, or here, or here. And in the follicle, you have germinal, mental zone, and germinal center. You gotta remember these. They do ask you about this. So follicle, located in outer cortex, site of B cell localization and proliferation. Primary follicles are dense and quiescent. Secondary follicles have pale central germinal centers and are active. Uh, you don't have to worry about the differentiation between the two types of follicles, just know what follicles are. Medulla consists of medullary cords, closely packed lymphocytes and plasma cells, and medullary sinuses contains reticular cells and macrophages. Medullary sinuses communicate with efferent lymphatics. Pericortex contains T cells, region of cortex between follicle and medulla. So that's right there, pericortex. Okay, so contains high endothelial venules through which T cell and B cells enter the blood. So the venules are these things right here. So they go straight into the paracortex and the germinal centers right there. Okay. Underdeveloped in patients with DeGeorge syndrome. That's when they don't have the thymus developed, so you won't have that. Paracortex enlarges in an extreme cellular immune response, for example, EBV and other viral infections. So that's when you have enlarged lymph nodes. Paracortical. So that will lead to pericortical hyperplasia, and you get lymphadenopathy and large lymph node otherwise. So this is your afferent lymphatic follicle, pericortex, cortex, postcapillary venule, capillary structure, trabecula, uh, capsule, medullary sinus is this, efferent vein, artery, medullary cords, mental zone, and germinal center, primary, secondary. So they might give you this kind of photo, and they'll ask you where would you find B cells. So then you would point this out. Where would you find? They only ask about B cell. They don't ask you about paracortex or T cells. But you need to know where it is. It's usually very obvious that these are germinal cells in the photo. Okay. Then you have germinal centers, sorry. Lymphatic drainage associations. Uh, lymph node cluster, area of body drained, and associated pathology. So submandibular, submental, area of body drain is oral cavity, anterior tongue, and lower lip. Associated pathology is malignancy of and metastasis to the oral cavity. So right there, submandibular and sublingual. Sorry, submental and submandibular. This is your deep cervical that drains head, neck, and oropharynx. Uh, you have upper respiratory tract infection or infectious mononucleosis or Kawasaki disease, malignancy of head, neck, oropharynx. You'll have lymphadenopathy over there. Supraclavicular is the important one that you need to know about. It drains the right hemothorax and left, which is the main thing over here, left hemothorax, abdomen, and pelvis. It's known as Virchow's node or Virchow's node. Uh, Associated pathology is malignancy of thorax, abdomen, and pelvis. And if there was a colon cancer or something, this is the one that would get affected if it's metastasized. Mediastinal is trachea, esophagus, and hilar lymph nodes are these. So that's mediastinal, that's hilar. Hilar lymph node is, it drains lungs. So you have all the lung diseases, pulmonary TB, sarcoidosis, lung cancer, granulomatous disease. Then you have axillary, upper limb, breast, skin above umbilicus. Okay, mastitis and metastasis, especially breast cancer. Sorry. So breast cancer is the one that you will know, like that's what they test you on. So when you're doing a repro, we'll come across it. But mostly, if you have, if this lymph node is hard or big, it's a question about breast cancer. Epitrochlear, that's right there, right around the trochlea. It drains the hand and forearm. Associated pathology is secondary syphilis. This will never come in test. I haven't seen it. Celiac is right there. Again, that's just upper part of abdomen, so you'll have liver, stomach, spleen, pancreas, and upper duodenum. Then you have superior mesenteric, that's the middle part of your abdomen, so that's your lower duodenum, jejunum, ileum, colon to splenic flexure. You have inferior mesenteric, that's the lower part of the duodenum, so that's colon from your splenic flexure to upper rectum. You gotta know splenic flexure, we'll go, that'll come as well. That's just a watershed area. So mesenteric lymphadenitis, inflammatory bowel disease, and celiac diseases, they all will affect lymph nodes anywhere around these three, or even all of them. Periumbilical or Sister Mary Joseph nodule is right there. It drains the abdomen and pelvis. Uh, this is for gastric cancer. Okay, and para-aortic. This is also very important because it drains pair of testes, ovaries, kidneys, and fallopian tubes. So they ask about this in repro. Uh, Again, metastasis for that. Uh, External iliac, internal iliac, superficial lingual, and popliteal. Okay, so it's up till from para-aortic to superficial inguinal. These are all going to be your repro ones. So external iliac is cervix, vagina, upper third, superior bladder, and body of uterus. Okay. Internal iliac is lower rectum to anal canal, above pectinate line, bladder, vagina, middle third, cervix, and prostate. Superficial inguinal is from anal canal. Since it's superficial, it's going to be things that are superficial, right? So it's going to be your anal canal below the pectinate line, skin below the umbilicus, except popliteal area, scrotum, vulva, and vagina, which is just the lower third of vagina. Because the middle third of vagina is over here, and upper third is over here. Uh, Associated pathology is sexually transmitted infections, medial foot leg cellulitis, superficial inguinal. That's where it goes. And popliteal or poplateral drains the dorsolateral foot or posterior calf, lateral foot, and or leg cellulitis. Okay. Right lymphatic duct drains right side of the body, above the diaphragm, into the junction of right subclavian and internal jugular vein. Right subclavian and internal jugular vein. Okay, so they do test you on this. So just know the right side goes into subclavian vein and internal jugular vein. On this side, it goes straight into jugular vein on the left side. Okay, okay, so also the ones that are like donuts, they're non-palpable lymph nodes, so you'll feel all of these, but the abdomen ones are hard to feel. The one you can feel is periumbilical one for gastric cancer. So if it's a question about palpable lymph node in the stomach, more than likely it's going to be gastric cancer. But along with this, you're also going to feel this one then, because malignancy of abdomen is associated with supraclavicular or workout node. Okay, spleen looks similar to a lymph node, but it's different. It functions the same almost. You have white pulp and red pulp. That's the red pulp right there, and the white pulp here. White pulp is for WBC, WW. Red pulp is for RBCs, RR. That's the trabecula, that's the capsule, germinal centers, mental zone, marginal zone. This is your follicle. This is your para arteriolar lymphoid sheath. So that's going to be, it's arteriolar lymphoid sheath. So that's going to be around your arterioles. Uh, so this is your vein coming in. This is your artery. That's how the WBCs and RBCs spread. This is your reticular fibrous network. Reticular just means net-like sinusoid. And this is your open circulation because it opens into the cavity, whereas here in closed circulation closes into the sinusoid. This is your pulp vein. Okay. So spleen is located in your lower upper left upper quadrant of abdomen. Uh, okay, Enterolateral to the left kidney. Enterolateral. So kidney would be behind the spleen, medially. Protected by the ninth and 11th ribs. Remember that? That it's ninth and 11th, 9 to 11th rib. Splenic dysfunction. For example, post-splenectomy, or sickle cell disease autosplenectomy. They both lead to decrease in immunoglobulin M, which is the one that's found the most in body because it's the largest, which also then leads to decrease in complement activation, which causes decrease in C3b opsonization, which increases susceptibility to encapsulated organisms because you're not going to have your MAC attack. Post-splenectomy findings are Howell-Jolly bodies, nuclear remnants, target cells. So we're going to look at what that is. Target cells, thrombocytosis, loss of sequestration and removal, lymphocytosis, loss of sequestration for this as well. Okay. Vaccinate patients undergoing splenectomy or with splenic dysfunction against encapsulated organisms. This is very important. So pneumococci, H. influenza B, and meningococci. So let's see what this is. Okay. Kind of looks like Heinz body, doesn't it? Okay, so it's similar to Heinz body. Look-wise, it's just darker blue. Target cells are easy to see. I'll do that. If you see a target cell, you can be sure that something's wrong with the spleen. So that would be your target cell right there. Okay, so after post-splenectomy, what happens is you'll find these things, right? That just means spleen is gone, but it's also called splenectomy by sequestration. So that's just when your spleen stops working. So you're gonna have splenomegaly in that case. So that's how you would know about that. And if it was palpable before, but then it's not palpable, it's because it's atrophied, and you'll have pneumococci infection or any encapsulated infection. Okay. Periarteriolar lymphatic sheath contains T cells located within white pulp. Okay. So T cells in white pulp. Okay. Periarteriolar. And in the follicles, you have B cell. That's quite convenient because even in this one, it was in the follicle. B cells are in follicles always. So follicles contain B cells located within the white pulp. Marginal zone was this, around the germinal centers. It contains macrophages and specialized B cells, site where antigen-presenting cells capture blood-borne antigens for recognition by lymphocytes, located between red pulp and white pulp. So the red pulp is this thing. So it's located between this and this. That's what he's saying. So right there. So infection would come in the arteries right here, and then it would get detected by these via APCs, or antigen presenting cells. Uh, there's this thing here, and it goes into all of this. We'll go over that when it comes. Thymus. Uh, okay, so that shadow right there is thymus. It's visible on a child, but not in an adult. Located in the anterior superior mediastinum, site of T cell differentiation and maturation. So that's where you have T cell differentiation and maturation over there. It's encapsulated. Thymus epithelium is derived from third pharyngeal pouch or endoderm, whereas thymic lymphocytes are of mesodermal origin. Cortex is dense with immature T cell. Medulla is pale with mature T cells. And okay, so remember that cortex has immature T cells. It should be somewhere here as well. Okay. So cortex is dense with immature T cells, whereas medulla is pale with mature, and it's convenient because M for medulla, M for mature T cells, and Hassel corpuscles containing epithelial reticular cells. Normal neonatal thymus is sail-shaped, so it looks like a sail, right? On chest X-ray. It involutes by age 3, so after age 3 it involutes, so you won't see it after that. T cells and thymus is for thymus, B cells is for bone marrow. But production happens there, it's just the maturation that it happens over here. Absent thymic shadow or hypoplastic thymus seen in some immunodeficiencies, for example, SCID or DiGeorge syndrome. This is an important one, so we'll just look at what that is. So DiGeorge syndrome is a primary immunodeficiency, often but not always characterized by a cellular T cell deficiency. Characteristic facies, congenital heart disease, and hypocalcemia. We'll come across it in this as well in patho, I think. Thymoma, neoplasm of thymus, associated with myasthenia gravis, superior vena cava syndrome, pure red cell aplasia, Good syndrome. So thymoma is a neoplasm of thymus. Okay, it's associated with all of these things. So if you have myasthenia gravis or superior vena cava syndrome, you have this because the thymoma will press against the superior vena cava, giving you the superior vena cava syndrome, which is just swelling of the face because it can't be drained anymore via superior, that thing. So SVC. Pure red cell aplasia is important to remember. It comes, and Good syndrome as well. What was Good syndrome? It's a rare condition with thymoma associated with hypoglycemic Hypo, okay. Cool. Immunology, cellular components, innate versus adaptive immunity. Innate immunity and adaptive immunity. The components for innate immunity are neutrophils, macrophages, monocytes, dendritic cells, natural killer cells, lymphoid origin, complement, physical epithelial barriers, and secreted enzymes. So you know what neutrophils are, macrophages are, monocytes are, dendritic cells, uh, natural killer cells, complement, we'll go over it if you're not sure of that. Physical epithelial barriers, that would be just your skin, something like that. And secreted enzymes are like your leukotrienes and all that, cytokines and stuff. Adaptive immunity is your immune stuff, T cell, B cell, and circulating antibodies. Okay, because they're the one that go through differentiation and maturation, and the antibodies develop against antigens that are presented to them by antigen presenting cells. So that's how they adapt to infection. This thing you're born with, all of these. So you come stock with these stuff. Mechanism is germline encoded. Adaptive immunity is variation through VDJ recombination during lymphocyte development. VDJ, that's on your, what do you say, antibodies, and then the recombination of those. So that's how you get a single, like, immunoglobulin G. It looks the same, but it's because of this why you have so many types of immunoglobulin G against a lot of other different things. So that's what VDJ is. So variation through VDJ recombination during lymphocyte development. So when it's developing, that's how the mechanism for adaptive immunity works. Uh, for this one, it's just in your DNA. Response to pathogens, non-specific. So if it doesn't have a particular marker, it's just going to attack it. So because those markers are found in your body, but it's not going to be found on like bacteria and stuff. So it's going to just attack it like that. Occurs rapidly, minutes to hours. No memory response. However, in adaptive, the response to pathogens is highly specific and refined over time as well. That's how your vaccination works. Develops over long periods. Memory response is faster and more robust. So if you had an option, you would pick this one over this one to fight an infection. Secreted proteins, lysozyme, complements, C-reactive protein, defensive, and cytokines. If you have done your internship rotation, you have seen this test before. It's just a test to tell you that there is some kind of inflammation happening. So that's why CRP is very important for test. It tells you if it is actually an infection or like inflammation or not. Adaptive immunity is immunoglobulins or cytokines. Okay, that's what the components are basically for them. Uh, Key features in pathogen recognition: toll-like receptors. That's gonna be okay. We'll do it when it comes. Toll-like receptors are on the membrane itself. Uh, so, they function by, or what is their function? It's pattern recognition receptors that recognize pathogen-associated molecular patterns, also known as PAMPs. They do use this acronym, so remember what PAMPs are. They're, again, pathogen-associated molecular pattern, and lead to activation of NFKB, okay, kappa B or whatever. I think that's nuclear factor kappa B. So when these are activated, you get differentiation in the macrophages, and they get activated as well. Examples of PAMP. Oh, okay, so it's LPS. So, okay, so LPS, gram-negative bacteria, flagellin bacteria, flagellin found in bacteria, LPS found in gram-negative bacteria, and nucleic acids in viruses. So get act, they will get recognized or attached to toll-like receptors, and then on the macrophages or whatever, or antigen presenting cells, and then they'll activate that stuff. The whole process of taking care of it. Adaptive immunity, how does that function? Or key features in pattern recognition is memory cells, activated B and T cells, subsequent exposure to a previously encountered antigen, which will lead to stronger and quicker immune response. Okay, so first time it takes time to build an immunity against it, but next time you get exposed to it, it's going to be a stronger and quicker immune response. Immune privilege. This is important. This is why if one eye is damaged, the person also loses the other eye sometimes, even though it wasn't damaged. Immune privilege in organs, for example, eye, brain, placenta, and testes. They test mostly about eye. They'll be like the person had an accident and his left eye was uh, damaged, but his right eye was okay. But 2 months later, the vision in the right eye is also being affected. Why? It's because of immune privilege. So, what is that? Organs and tissues where suppressive mechanisms limit immune responses to foreign antigens to avoid damage that would occur from inflammatory sequelae. Allograft rejection at these sites is less likely. Okay, so basically what it is the immunity does not travel here. So that's this stuff is foreign to our body. So if somehow an antigen presenting cell reaches an eye, or you know there's a antibody against anything inside of this, then it's going to go out and attach to anything that resembles it, because it doesn't have the markers that other cells of the body have. So that's why when you damage your eye, you have some kind of uh, immune cells leak into it, and then it's gonna recognize it as a foreign particle or foreign body, and then it's gonna go look for it everywhere else, and that's why you lose the other eye as well. Okay, we have 10 minutes. So I'll read that again. Organ and tissues where suppressive mechanisms limit immune responses to foreign antigens to avoid damage that would occur from inflammatory sequelae. Allograft rejection at these sites is less likely. That's why we have a lot of successful eye implants, I'm thinking. Okay. Uh, we'll take a break here and continue after this. Compatibility complex 1 and 2. MHC, that's okay. Encoded by HLA gene, present antigen fragments to T cell and bind T cell receptors or TCRs. You have MHC1 and MHC2. MHC1 has HLA A, B, and C. MHC1 loci have one letter. Binding is with T cell receptor and CD8. That's the important one. You need to know about CD8. Structure, one long chain and one short chain. Expression, so that's one long chain, this whole thing, and then one short chain is this one right here. Expression is all nucleated cells, APCs, and platelets have these, except for RBCs. RBCs don't have it. Okay. Function presents endogenous antigens, for example, viral or cytosolic proteins to CD8 plus cytotoxic T cells. Antigen loading. Antigen peptides loaded onto MHC1 in RER after delivery via TET transporter associated with antigen processing. Associated proteins, beta-2 microglobulin structure. You need to know that this one has long chain and short chain. You need to know that it binds to CD8. So 8 times 1 is 8. 4 times 2 is 8 is how you can remember that. Then antigen peptide loaded onto MEC1 in RER after delivery via TAP. That is important as well. So that, and yeah, only one letter to one low for MHC1. For MHC2, you have two letters, HLA-DP DQ, and DR. MHC2 loci have two letters. Again, it binds to T cell receptors and CD4. Here was CD8, here's CD4. 4 times 2 is 8. Structure is two equal length chains. You have two alphas and two betas, both the same side length. Expressions are only on APCs. You won't see it on platelets or nucleated cells, but only APCs. Function is it presents exogenous. Here it was inside, here it's outside. So presents exogenous antigens like bacterial proteins to CD4 plus helper T cells. Antigen loading. Antigen loaded following release of invariant chain in an acidified endosome. Antigen loaded following release of invariant chain in an acidified endosome. Not sure what that means. Associated proteins. Invariant chain. Okay. So here the important thing is you gotta know HLA, DP, DQ, and DR. CD8, long chain, two alphas and betas, and it's only found on APCs, and it presents exogenous antigen. So yeah, they test you on every single thing over here. This one I'm not too sure. They usually test you on this part right here. That's why I'm not sure about what this says. HLA subtypes associated with diseases. HLA subtype, disease, and mnemonic. B27, psoriatic arthritis, ankylosing spondylitis. IBD, associated arthritis. Reactive arthritis. Mnemonic is pear. Okay. So when you see B27, you're always going to think about ankylosing spondylitis. That's what it's known for on steps. But you also need to know that it's associated with other types of arthritis. Psoriatic, uh, inflammatory bowel disease associated, and reactive arthritis. Okay. B57 is for abacavir, hypersensitivity. DQ is for Dairy Queen, or DQ2 and DQ8. It's for celiac disease. So I ate too much gluten at Dairy Queen. Uh, DR3, DM type 1, SLE, Graves' disease, Hashimoto thyroiditis, Addison's disease. DM type 1, HLA3 and 4. 1 plus 3 equals 4. SL3. Okay. DR4, rheumatoid arthritis, DM type 1, Addison's disease. There are 4 walls in a room. They test you on all of these subtypes. I'm not sure about B57, but they test you on the other ones. So DR3, DM type 1, SLE, Graves' disease, Hashimoto thyroiditis, and Addison's disease. And DR4 is 4 walls in one room, so rheumatoid arthritis. DM1 and Addison's disease. For this, the questions would be like they'll give. They found the HLA subtype DR4. What could be the reason? It's because it's something. The mechanism of this, so it would be like because of antigen antibody found somewhere. That's why the symptoms are happening, something like that. So they'll give you this, but then you have to connect it to this somehow, like that. Functions of natural killer cells. Lymphocyte, member of innate immune system. Use porphyrin or gramzyme to induce apoptosis of virally infected cells and tumor cells. Activity enhanced by interleukin-2, interleukin-12, interferon alpha, and interferon beta. Okay, so natural killer cells, again, that was your innate immune system. They use perforin and granzymes, and they induce apoptosis. They basically kill the cell. That's why they're called natural killer cells uh, of virally infected cells and tumor cells. Activity is enhanced by interleukin 2, 12. We're going to learn about those. Interferon alpha and beta, we'll learn about those as well. Uh, Induced to kill when exposed to a non-specific activation signal on target cells and or to an absence of an inhibitory signal such as MHC1 on target cell surface. So they're induced to kill when exposed to non-specific activation signal. So it could be anything that doesn't seem like it's part of your body. Uh, it will activate it. On target cells and or to an absence, so that's the one I was talking about, absence of inhibitory signal, such as if it doesn't have MHC1, it's going to attack it. Also kills via antibody-dependent cell-mediated cytotoxicity. CD16 binds Fc's region of bound immunoglobulin G, activating the NK cell. So also kills via antibody dependent cell-mediated cytotoxicity. So this can function by its own, or it can be recruited by something. So when CD16 binds to F's region of immunoglobulin G, that will activate NK cell. You need to know that it's CD16 for natural killer cells. Major functions of B and T cells. B cells, humoral immunity, recognize and present antigen, undergo somatic hypermutation to optimize antigen specificity, produce antibody, differentiate into plasma cells to secrete specific immunoglobulin, maintain immunologic memory, memory B cell persists and accelerates future response to antigen. Okay, so this is your humoral immunity. It recognizes and presents antigen, undergoes somatic hypermutation to optimize antigen specificity. That's how it targets and focuses itself on that. Produce antibody, differentiates into plasma cells to secrete specific immunoglobulins. Okay, and maintain immunologic memory. Memory B cells persist and accelerate future response to antigen. So that's what that's for. T cell is cell-mediated immunity. CD4 plus T cells help B cells make antibodies and produce cytokines to recruit phagocytes and activate other leukocytes. That's the function of that. It makes antibodies and produces cytokines to recruit phagocytes, that's your macrophages, and activate other leukocytes. CD8 T cells directly kill virus-infected and tumor cells via perforin and granzymes, similar to NK cells. Delayed cell-mediated hypersensitivity, okay, and acute and chronic cellular organ rejection. So in type 4 sensitivity, you're gonna have T cell mediated reaction. For this part, I do have it in notes, so let's look at that. Uh, Um, okay, so you have APC coming in and attaching to T helper cells with CD4. So when CD4 is attached, it will, uh, with the help of interferon gamma and interleukin 12, uh, it's going to recruit Th1. Then Th1 with interferon gamma and this time interleukin 2, it's going to recruit macrophages. Uh, Macrophages have CD14, CD40, and CCR5 markers. and they have receptors, and FC and C3b receptor over here. Okay. Then macrophages itself also recruits Th1 cells via interleukin-12. So that's a little loop right there. So macrophages will recruit more T episodes to recruit more macrophages. Okay. And Th1 can also recruit CD8 cells, which are cytotoxic T cells, with the help of interferon gamma as well, and interleukin-2. So interferon gamma and interleukin-2 recruit both CD8 cells and macrophages. CD8 are cytotoxic T cells by itself, right? So this is cellular immunity. Okay, so that's what this was. CD4 T cell help B cell make antibodies and produce cytokines to recruit phagocytes, that's macrophages, and activate other leukocytes, other cells, WBC cells. CD8 T cells directly kill virus-infected and tumor cells via perforin and granulomas, similar to NK cells. So that's why this is not a loop. It's as long as you recruit this one, it's going to take care of the business. Also, this NK cell is CD16 and CD56. Okay, that covers that. Differentiation of T cells. So you have these many types of T cells. These right here. So how do we get there? It goes from bone marrow to thymus to lymph node, to be spread out through and function in peripheral blood. Okay, it starts off with T cell precursor, uh, which would have CD4, CD8, and T cell receptor. It binds to MHC1 or MHC2. So while it's here in the cortex, remember that it was immature cells. So in cortex, positive selection will bring you over here. In medulla, negative selection brings you over here. Medulla is the mature T cells, so it's going to have either the CD8 or CD4. If it has both the markers, it's still immature and it's going to be in cortex. The CD8 will then go into lymph node and function as a cytotoxic T cell. That's the end of that. CD4 will go into lymph nodes and function as helper T cell. So this is what this diagram is right here. Th1, Th2, you have Th17 and Treg. So Th1, interferon gamma, interleukin-12, right? It secretes, we already know, activates macrophages and cytotoxic T cell. So you should remember that now. This process is inhibited by interleukin-4 and interleukin-10. Why interleukin-10 is right here. It's also known as anti-inflammatory cell. So it avoids recruiting of cytotoxic cells and all that stuff, and prevents inflammation basically. Inflammation is what recruits neutrophils and macrophages, right? So since this is anti-inflammatory, it attenuates inflammatory response, decreases expression of MHC class 2 and Th1 cytokines, inhibits activated macrophages and dendritic cells, also secreted by regulatory T cells. So TGF-beta and interleukin-10 both attenuate the immune response. Interleukin-4, it induces differentiation of T cells into Th2 cells, promotes growth of B cells, enhances class switching to immunoglobulin E and immunoglobulin G. Okay, we'll come to that later. But there you have it for interleukin-4 and 10. So why is this inhibited by interleukin-4? It's because interleukin-4 is meant to activate Th2. What does Th2 do? It activates eosinophils. It increases immunoglobulin E, right? Oh, gonna meet you, bro. Okay. So we'll look at the diagram. So interleukin 2 and 4 come in and activate Th2s. This is going to be your humoral immunity. Eosinophils, mast cells, and basophils, they all recruit Th2. Then with the help of interleukin 4 and 13, there's going to be B cell activation and immunoglobulin E production. With the help of interleukin 5, that's important. It's going to recruit eosinophils. With interleukin 10, it's going to make macrophages. Okay, so you have interleukin 4 and interleukin 10, the anti-inflammatory cell. They're going to recruit macrophages. Okay. The B cell, it's known for CD19, CD20, and CD21. So those are its markers. MSC2, B7, and CD40 are also on it. But these ones are the most important ones, CD19, 20, and 21. You will be asked questions on it. Like they'll just give you that there's a cancer and then the markers on the cancer is CD20. What kind of cancer can it be? Then you'll have like B cell lymphoma or something. Okay. Helper T cell. You have TGF beta, also anti-inflammatory. Interleukin 1 and 6, these are inflammatory. It's inhibited by interferon gamma and interleukin 4. What does it do? It induces neutrophilic inflammation, right? So, induces neutrophil inflammation. Interleukin 1, 6, and TGF beta. Interleukin 17, 21, and 22. And then we have Treg. Treg is activated by TGF beta and interleukin 2. Same as this one, interleukin 2 here. You have TGF beta here. And is inhibited by inflammatory interleukin 6. With the help of TGF beta, interleukin 10, and IL-35, it prevents autoimmunity. So it maintains tolerance. So this is why your own cells don't attack your other body cells, like your own cells. Okay, so again, Th1 secretes interferon gamma and interleukin 2. Th2 secretes interleukin 4, 5, 6, 10, 13. Th17 secretes interleukin 17, 21, and 22. Treg secretes TGF beta, interleukin 2, and interleukin 35. What's important in this? These two are very important. You'll be tested on that. They test you on this as well. The positive and negative selection. Which part of it contains what kind of T cells. So we'll do that now. Positive selection, thymic cortex, double positive, CD4, CD8. It's going to have both. T cells expressing TCRs capable of binding self-MHC on cortical epithelial cells to survive. Negative selection, thymic medulla, T cell expressing TCRs with high affinity for self-antigens. undergo apoptosis or become regulatory T cells. Tissue-restricted self-antigens are expressed in the thymus due to action of autoimmune regulator. Deficiency lead to autoimmune polyendocrine syndrome 1. Chronic mucocutaneous candidiasis, hypoparathyroidism, adrenal insufficiency, recurrent candida infection. Without air, your body will char or chair, I guess. Okay, so negative selection again, thymic medulla, T cells expressing two of them, TCRs with high affinity for self-antigens undergo apoptosis. So that's just saying that the ones that are very enthusiastic and are very happy to be here are gonna go under apoptosis, because we don't want that. We don't want high affinity for self-antigens, because then it's gonna start attacking your own body cells, or become regulatory T cells, or they're gonna turn into these things, which is gonna then, compensate for all that superiority complex into preventing autoimmunity, I guess. Tissue-restricted self-antigens are expressed in the thymus due to action of autoimmune regulator. Air deficiency leads to autoimmune polyendocrine syndrome 1, chronic mucocutaneous candidiasis, hypoparathyroidism, adrenal insufficiency, recurrent candida infections. Without air, your body will char. Okay. You need to know these. That's why I'm going over it again. Tissue-restricted self-antigens are expressed in thymus due to action of autoimmune regulator. That's AIR. Deficiency leads to autoimmune polyendocrine syndrome, or 1. -1. This is when you have chronic mucocutaneous candidiasis, hypoparathyroidism. So they'll give you that. They'll give you that the person has maybe oral thrush. They have decreased PTH and some form of adrenal insufficiency. And then you're supposed to figure out that it's because they're suffering from air or R, right? Okay. They'll also give you that. They might give you that the cells have both the receptors on it for CD4 and CD8. Okay. Uh, Macrophage lymphocyte interaction. Th1 cells secrete interferon gamma. We already know that, which enhances the ability of monocytes and macrophages to kill microbes they ingest. This function is also enhanced by interaction of T cell CD40L and CD40 on macrophages. Macrophages have CD40 and CD40L on it. Interaction of T cell CD40L. So CD40L is on T cell, not macrophage. My bad. So L is for ligand, so it links to CD40 on macrophages. That's how that functions. Macrophages are also activates lymphocytes via antigen presentation. Then you have cytotoxic T cells, that thing right there, or right there, cytotoxic T cell. It kills kill virus-infected neoplastic and donor graft cells by inducing apoptosis. How does it do that? It releases cytotoxic granules containing preformed proteins, which are your perforins and granzyme B. Cytotoxic T cells have CD8, which binds to MAC1 on virus-infected cells. Okay, so cytotoxic T cells have CD8 which binds to MHC1. We know that as well on virus infected cells. So it's your cells that have virus in it, and then it's that virus is gonna go to tap protein, right? That was right there. Antigen peptide loaded onto MHC1. Your tap protein is in the RER, or rough endoplasmic reticulum. So after that, it's gonna go outside and present it to the T cell, like that. Regulatory T cell helps maintain specific immune tolerance by suppressing CD4 and CD8 T cell effector function, identified by expression of CD3, CD4, CD25, and FOXP3. Activated regulatory T cells produce anti-inflammatory cytokines, which are interleukin-10 and TGF-beta. We know that these are anti-inflammatory. They'll test you on that. That's not, the patient was given some kind of interleukin that suppressed the redness or the swelling. So it's going to ask you which one would it be. Then they're going to name all the numbers like 2, 3, 10, 15, 20, whatever. And you need to know that only interleukin 10 will do that, or TGF-beta. You need to know the function of regulatory T cell. It helps maintain specific immune tolerance by suppressing, these things from attacking yourself. T cell effector functions, identified by expression of. So regulatory T cells have CD3, 4, 25, and FOXP3. Yep, you need to know that too. CD3, CD4, FOXP3. I think that's CRR5. Inflammatory cells are these: interleukin-1, 6, and TNF-alpha. They recruit interleukin-8 and 12. You have anti-inflammatory interleukin-10 and TGF-beta. So hopefully you remember that now. IPX, immune dysregulation, polyendocrinopathy, enteropathy, X-linked syndrome. Genetic deficiency of FOXP3 will lead to autoimmunity. That's when it starts attacking your own cells. Characterized by enteropathy, you'll have that. You'll have endocrinopathy. You'll have neodystrophy, dermatitis, and or other autoimmune dermatologic conditions associated with diabetes in male infants. I have come across one question that had this. Give me a second. Okay. So you do need to know this. IPEX is immune dysregulation, polyendocrinopathy, and enteropathy. So you're gonna have uh, hormone issues or some kind of endocrinopathy of such, and enteropathy. So you're gonna have stomach problems, some kind, and immune dysregulation. They'll give you these three. You just need to identify these things, and it's X-linked. So I don't think they might say the family history is that the brother has it or something like that. Okay. Associated with diabetes and male infants. Might give you that too. Since it's polyendocrine. Okay. Next. T and B cell activation. So how does it happen? What are these CD, whatever we went over, CD4, CD8, all that stuff. So APCs, B cells, dendritic cells, Langerhans cells, and macrophages Two cell signals are required for T cell activation, B cell activation, and class switching. Okay, so APCs are B cells, dendritic cells, Langerhans cells, and macrophages. Know that which ones are antigen-presenting cells. Notice how T cell is not there. So it's your B cell, dendritic cell, Langerhans cells, and macrophages. Two signals are required for T cell activation, B cell activation, and class switching. So how the mechanism or how T cell activates. First, the APC ingests and processes antigen, then migrates to the draining lymph node. So it comes in here, antigen presenting cell. Antigen presenting cell, and then it goes either to MHC2 or 1, and that will attach when it attaches to T cell receptor, along with this thing right here, which is your, okay, so I'm going ahead. 2. T cell activation. Signal 1. Exogenous antigen is presented on MHC2 and recognized by T cell receptor on Th or CD4 cells. Endogenous or cross-presented antigen is presented on MHC1 to Tc or CD8 cells. Okay, so this thing right here, it's talking about this thing. So you need these two to happen together for this to happen. If only TCR is attached, but then you don't have this cross, what is it? It's not going to happen. So I guess it's really 3 things that needs to happen instead of 2. Okay. So so first signal is exogenous antigen is presented on MHC2 and recognized by TCR on TS cells. So that's your TCR. Endogenous or cross-presented antigen is presented. Okay, I got it. I'm just getting confused on my own. Okay. So when it's something in the genus, it's going to be in here already. That's going to be presented to CD8. But if it's coming from outside, it gets presented to CD4 on the T cell receptor. So then when that happens, there will be proliferation and survival of survival. So that is your signal 2. Costimulatory signal via interaction of B7, that's the CD80 to CD86. You need to know that. They don't ask you about B7, they ask you about CD80 and 86. So costimulatory signal via interaction of B7 protein, CD80 by 86 on dendritic cell, and CD28 on naive T cell. Okay, so also remember which ones are on which. So naive T cell, the T cell will have the CD28 and CD4 and 8. The antigen presenting cells have the MHC1 or 2 or CD80 and 86. That makes sense because APCs are these and you don't have T cells in there. So they won't have those. What T cells will have is this. TCR, CD8, CD4, and CD28. So when that happens, there will be activated T helper cells produce cytokines. TC cells able to recognize and kill virus-infected cells. So that's going to go into action right there. So that's how that works. It's important to know these connections and what they're called. For B cell, it's similar. So after this happens, T cells are activated. Th cell activation as above. B cell receptor mediated endocytosis happens. Okay, so now you have T cell going into, okay, wait, activated T cells, okay. So they'll go and attach to the B cells or antigen presenting cells or whatever. So antigen is coming here and here. It's going to go through the MHC again to the T cell receptor, present it to, since it's MHC2, it's going to present it to CD4. Okay. So TH cell activation is above. B cell receptor mediated endocytosis. Exogenous antigen is presented on MHC2 and recognized by TCR on TH cells. 4. CD40 receptor on B cell. So remember that CD40 receptor cell is on B cell, which binds to CD40 ligand on the TH cell, so CD40L, right? Don't confuse the two. Ligand is on T cells and CD40 is on B cell. 5 is TH cells secrete cytokines that determine immunoglobulin class switching of B cells. Okay, so when that happens, T cell is then, after this thing comes in, it's gonna do its thing and then it's gonna release the cytokines, and these cytokines are gonna then activate the B cell. So TH cells secrete cytokines that determine immunoglobulin class switching of B cells. So these cytokines are what determines what class or which class the B cell should be. Then B cells are activated and produce immunoglobulin N. They undergo class switching and affinity maturation. So that's pretty simple, like that. You need to know this thing right here. Mostly what the question is going to ask about is it's going to test your knowledge about this system right here. Who brings in the antigen? What does what is used to attach to the T cell? What markers are on T cells? Stuff like that, and how the class switching works. So there are two things that get secreted, right? First, the antigen from here to here, and then the cytokines from here to here, and that's how you get immunoglobulin M from B cells. B cells come from plasma cells, right? I think. No. I need to go to the basics. We'll do that in a minute. Immunology, immune responses. Okay. Antibody structures. This is important too. Fab fragment consisting of light and heavy chains recognizes antigens. Fc region of immunoglobulin M and immunoglobulin G fixes complement. Heavy chain contributes to Fc and Fab regions. Light chains contribute only to Fab region. So when you see CH, that's heavy chain, and when you see Cl, those are your light chains. So what it's saying is Fab fragment consists of light and heavy chains. So these are your Fab regions right here. This thing. And this is your Fc region. So your Fab region is fabulous because it contains both classes, Cl and Ch. Fc region of immunoglobulin M and immunoglobulin G fixes complement. That is an important line. They test you a lot on this line right here. So Fc region is the one that binds to the complement or fixes to the complement in immunoglobulin M and G. Heavy chain contributes to Fc and Fb, but light chain only contributes to Fab region. So light chain is only here, whereas heavy chain is here on both sides. This is the macrophage binding and complement binding area, Fc region. Light chain, this is the VDJ, that's the one that changes around so that in one immunoglobulin it can function like immunoglobulin G can go against many different types of antigen. It's because of this variability. Uh, so FAB, fragment antigen binding, fragment antigen binding. Okay, so antigen is gonna bind over here. It's called the FAB region, antigen binding site. This is the epitope right there. They ask about that too. Determines idiotype, unique antigen binding pocket, only one antigenic specificity expressed per B cell. So per B cell, you only have that uh, one antigen specificity. FC region is known for being constant carboxyl, having carboxy terminal, complement binding, uh, carbohydrate side chains, and determines the isotype. Like, is it going to be immunoglobulin M or is it going to go into being immunoglobulin D, etc. Generation of antibody diversity, antigen independent. Uh, 1. Random recombination of VJ, light chain, or VDJ, heavy chain genes by RAG1, RAG1, and RAG2, RAG2. 2. Random addition of nucleotides to DNA during recombination by terminal deoxynucleotide transferase or TDT. 3. Random combination of heavy chains with light chains. Okay, so that's how you generate antibody diversity. So this one is the important one, and this one. You should just know about that. They don't really test you, but it will come in a question stem, and then you should know what it means when they say that. Generation of antibody specificity, antigen dependent. Okay, so how does it get specific? Somatic hypermutation and affinity maturation, variable region, and isotope switching in the constant region. Okay, so constant region is the C ones. Know this, neutralization. Antibody prevents bacterial adherence. Okay, so this is a bacteria and has immunoglobulin attached to it. So now this thing can't attach to the brush border. Right, so antibody prevents bacterial adherence to the brush border. This is neutralization. Then opsonization comes. This is when antibody promotes phagocytosis. When it attaches to the epithelium or whatever, the lining, it's gonna, what's it gonna do? It's gonna activate things around it that's gonna make it. So like, okay, so there's like say a phagocyte, right? So macrophage. So when it attaches to the macrophage, it's gonna activate it to uh, phagocyte or eat it basically. Okay. Wow, that struggle is real. Complement activation, MAC or membrane attack complex. So it can do this as well. Antibodies activates complement, enhancing opsonization and lysis. Attaches to C3B. Okay, and that's how it does. So you should know how it works. It neutralizes, it opsonizes, and it also causes complement activation. Immunoglobulin isotype. I think 10 minutes left. Okay, I'll go through this as much as I can. Immunoglobulin isotype Isotypes can exist as monomers. Mature naive B cells prior to activation express immunoglobulin M and immunoglobulin D on their surfaces. They may differentiate in germinal centers of lymph nodes by isotype switching, that is gene arrangement, which is induced by cytokines and CD40L into plasma cells. Okay, there you go. That secretes immunoglobulin A, immunoglobulin G, or immunoglobulin E. For B cells, immunoglobulin M or mom or immunoglobulin D or dad mature to plasma cells as they age. No, I don't like that. Affinity refers to the individual antibody-antigen interaction, while avidity describes the cumulative binding strength of all antibody-antigen interactions in a multivalent molecule. Uh, Know this, all types exist as monomers. Mature naive B cell prior to activation express. So right before they're activated, they express immunoglobulin M and immunoglobulin D, these two. So mom and dad, I guess. Okay, it's working. uh, yeah, so know that. They may differentiate in germinal centers, we already know that, of lymph node by isotype switching, we know that, into plasma cells, and plasma cells that secrete immunoglobulin A, G, or E. So that's D gain, or gain D. Okay, I'll go into this in the next one. Okay, so affinity refers to the individual antibody-antigen interactions, while avidity describes the cumulative binding strength of all antibody-antigen interactions in a multivalent molecule. Immunoglobulin G, that's what it looks like, main antibody and secondary response to an antigen, most abundant isotype in the serum, fixes complement, opsonizes bacteria, neutralizes bacterial toxins and viruses. Only isotype that crosses the placenta, this is an important line, it's the only isotype that crosses the placenta, provides infants with passive immunity that starts to wane after birth. So immunoglobulin G greets the growing fetus. Associated with warm autoimmune hemolytic anemia. They test you on that too, but you also need to be able to recognize what this is. Autoimmune hemolytic anemia. So warm weather is great. That comes in HEMAT. Immunoglobulin A has a J chain. So it's just 2G IgGs with a J chain. Prevents attachment of bacteria and viruses to mucous membrane. Oh yeah, this one is found in GI tract. It prevents bacteria and viruses attachment to the mucous membrane. It does not fix complements though. Monomer in circulation or dimer with J chain when secreted. Crosses epithelial cells by transcytosis, produced in GI tract. Right, so it's produced in GI tract by Peyer's patches. That's the lymphoid tissue in your intestine, small intestine, and protects against gut infection. For example, Giardia. That's when it's going to be tested in Giardia questions. Also, like other stuff which attaches to GI tract. For all of them, IgA is responsible for their prevention. Most produced antibody overall, but has lower serum concentrations, released into secretions, tears, saliva, mucus, and breast milk, picks up secretory component from epithelial cells, which protects the Fc portion from luminal proteases. Okay, so it picks up secretory components from epithelial cells, which protects the Fc portion from the luminal proteases. IgA is released into secretions like tears, saliva, and mucus, and breast milk. Immunoglobulin M, its joint monomers. It's produced in the primary or immediate response to an antigen. So out of all of them, the first thing that's going to happen is this, and then it's going to switch into the other ones, I guess, besides B. D. So fixes complement, antigen receptor on the surface of B cells, monomer on B cells, pentamer with J chain when secreted. Pentamer enables avid binding to antigen while humoral response evolves, associated with cold autoimmune hemolytic anemia. So this is the cold one. The warm one is IgG, because warm weather is great. So M is associated with the cold autoimmune hemolytic anemia. IgD, its function is unclear. It's found on surface of many B cells in serum and in serum. IgE, it binds mast cells and basophils, cross-links when exposed to allergen, mediating immediate type 1 hypersensitivity through release of inflammatory mediators such as histamine, contributes to immunity to parasites by activating eosinophils. So it's known for mast cells and basophils. So it's known for allergy. So it cross-links when exposed to allergens. It's also known for its immunity against parasites because it activates eosinophils. Okay. Antigen type and memory. Sorry. Antigen type and memory. Thymus independent antigen. So thymus independent antigen. Antigens lacking a peptide component, for example, lipopolysaccharides from gram-negative bacteria. They cannot be presented by AMC to T cells. Weakly immunogenic, vaccines often require boosters and adjuvants. For example, capsular polysaccharide subunit of Streptococcus pneumoniae or PPSV23 vaccines. This is an important concept to know. They test you a lot on this. They'll ask you, why is this required for a vaccine that treats pneumonia? So, yeah. Or the other way, I forget. But it's something to do with that. Thymus-dependent antigen is antigens containing a protein component, diphtheria toxoid. Class switching and immunologic memory occur as a result of direct contact of B cells and Th cells. So the ones that are dependent on thymus, antigens containing a protein component, like diphtheria toxoid, because that's a component of diphtheria. Class switching and immunologic memory occur as a result of direct contact of B cells with Th cells. Okay. complement. So this is the complement system. Before we go on to that, we'll look at this thing they ask about B cells. Immunosense, or just what happens when you grow older or in older patients compared to a younger one or a young adult. So B cells, there's decrease in production of naive B cells. There's no change in antibody quality though. So this is decreased. How about T lymphocytes? T lymphocytes are decreased naive CD4 T cells and increased memory CD8 T cells. Okay, so you have decreased CD4 T cells, but you have increased CD8 T cells. So remember that CD8 T cells are the only thing that increases out of all of them. All of this. That's why that thing is important. Increase in memory CD8 T cells. For macrophages, there's decrease in phagocytosis. There's decreased response to cytokines. For neutrophils, there's decreased chemotaxis and phagocytosis. Okay. So neutrophils, decrease in chemotaxis and phagocytosis, decrease in free radical production. In dendritic cells, there's decrease in antigen presenting capability, decrease in cytokine production. For NK cells, there's decrease in cytotoxicity and decrease in cytokine production as well. So remember about this thing, that's the most important one. This is the only thing that increases as you grow older. Memory CD8 T cells, which makes sense because now you have accumulated a lot of memory as you grow older. So that's the only thing that's gonna increase. Okay, hello. Okay, let's continue. Complement. A system of hepatically synthesized plasma proteins that play a role in innate immunity and inflammation. So I have a diagram for that. This is the one that they use in UWorld. Okay, so I'll just keep that here. Complement. System of hepatically synthesized plasma proteins that play a role in innate immunity and inflammation. Membrane attack complex. Defense against gram-negative bacteria. So this is its main function for MAC. It defends against gram-negative bacteria. The CH50 test is used to screen for activation of classical complement pathway. You don't need to know what this is as long as you know how this whole thing functions. So we'll just do that instead. Activation pathway is classic. Sorry. So activation pathway is classic. That includes the immunoglobulin G or immunoglobulin M mediated. Alternative pathway is microbe surface molecules. That's what it includes. Then you have lectin, which is mannose or other sugars on microbe surface. They'll activate the MAC complement system. So either mannose or sugar or microbe surface molecules, or it's presented by the antigen cells, and then you get plasma cells, and then the class switching, and then you get the IgG and IgM recruiting this. Function, you need to know these as well. So C3b is known for opsonization. Anything that has A in it, so C3a, C4a, C5a, they're known for anaphylaxis. So if you have an anaphylactic shock, it's these things that are responsible for it. C5a, along with anaphylaxis, also does neutrophil chemotaxis. And then you have C5b to 9, which is your MAC. Cytolysis. Okay. C3b binds to lipopolysaccharides on bacteria. MAC complex is important for neutralizing Neisseria species. This is the thing they test you on. That this person has whatever gram-negative infection, and it looks like it's Neisseria, and then they ask you, why is this happening? It's because their MAC complex is not functioning properly, or they have a lack of MAC. I think that rhymes. So deficiency results in recurrent infection. Opsonins are C3b and immunoglobulin G. Alright, so you have C3b, but also IgG are the two primary opsonins in bacterial defense. So they'll ask about this as well. They'll give you all the presentation that, or the question stem will state that the thing is being phagocytized, and there's some kind of thing that's detected there. What's it gonna be? You're gonna look for C3b, but it's not gonna be there. But they'll give you IgG, but then you're not gonna remember that because you remember this and not this. So remember that it's IgG as well, along with C3b. C3b and IgG are the two primary opsonins in bacterial defense, and they enhance phagocytosis. C3b also helps clear immune complexes. Okay. So opsonin is a Greek word which is to prepare for eating. Inhibitors, decay accelerating factor, or DAF. They're also called CD55 and C1 esterase inhibitor. They help prevent complement activation on soft cells. This is very important, along with Treg. This is also the thing that prevents complement activation on your own cells, right? So Treg was for T cells. This one is for MAC. It's CD55 and CD59. So here. So you got DAF CD55 and MERL CD59. Okay. So they prevent what? Complement activation on soft cells. Okay, so this thing, we'll go through this first, and then we'll go look at this. This one is less complicated, and this is what they test you on anyways. But classic pathway starts with C1, right? So C1. Lectin starts with C1 like complex. They both go into either C2, C2b, or C4 or C4b to make C3 convertase. C3 convertase goes into C3b. Alternate pathway starts off with C3 and C3b with I guess factor B or with factor D added to it to make factor big B and small b. They go into C3 convertase as well, and both the convertases go to C3b, which then leads to C3-5 convertase, and C3-5 convertase is necessary for MAC complex, which is C5. So C5 convertase plus C5 goes into C5b, and this is what the MAC complex is, C5b to C9. What do? They do lysis and cytotoxicity. Right, so this is the thing. Classical pathway. Bacteria, you have surface markers or something like that. Let's get here. IgG is attached to the bacteria. So that will be your C1 complex, QRNS. That plus C2 and C4 will make C3 convertase. For alternative C3, C3A, and C3B, you have this micro and its surface marker with factor B and D. What is B and D factor? Okay. It goes into C3 convertase as well. Now you have lectin with the sugar, mannose or other sugars, that mannose-rich moiety. This is C1-like complex, MBL and that, with C4 and C2. So it goes into this and goes into making MAC. The questions they ask about this is that they were checking for if the MAC complex is working or not. So they found out that there's a decrease in C4 and C2, but C1 is normal in serum. So when you have that, you're going to think about what C2 is here and C4 is here. So these two are decreased. Why would it decrease? It's because it's being used up, right? So it could be classical or lectin. They both have C1s, right? But C1 is normal, like this one. This is not C1, it's like C1, but it's not C1. So it's this one. So then you're going to think about, okay, so it's going through lectin pathway, right? Similarly, they'll give you that factor B is used up and C3 is normal over here, right? So then you would think alternative like that. So that's how they test you on this. There was also another question where you had to figure out. It's similar though. I can't recall right now. But they gave you. They asked about this, and they gave you factor B, and they said that C3A is increased, but C3B is decreased, something like that. So similar way of getting the answer, and that's how you get MAC attack. Okay, complement disorders, complement protein deficiencies. Early complement deficiency is C1 to C4. Okay, so that's this area, C1 to C4. If you have deficiency of that, you'll have increased risk of severe recurrent pyogenic sinus and respiratory tract infection. C3b used in clearance of antigen-antibody complex. That's what the function of C3b is. It's also your opsonin, right? C3b, because it helps clear immune complex. That's what it's saying. So C3b used in clearance of antigen-antibody complex. This leads to increased risk of SLE, right? Systemic lupus erythematosus. Then you have terminal complement deficiency. That's your MAC complex deficiency, or C5, C9. This will increase susceptibility to recurrent Neisseria bacteremia. So if you have that Neisseria, always think about this first, that there might be a MAC deficiency. Complement regulatory protein deficiencies. C1 esterase inhibitor deficiency. It causes hereditary angioedema. You should know this. It's tested in like a lot of chapters. You should also know what this looks like. They're gonna have cough. They're gonna have swelling in the face. It's gonna be red. It causes hereditary angioedema due to unregulated activation of kallikrein, which leads to increase in bradykinin, characterized by decrease in C4 levels. So you don't have this, right? C4 levels, okay. ACE inhibitors are contraindicated because they also increase bradykinin. So C1 esterase is the one that breaks down bradykinin. So when you don't have that, you're going to have increased bradykinin. And then if you give ACE inhibitor on top of that, you're going to have more bradykinin than previously stated. So then they're going to go into like rigorous coughing. And this thing causes hereditary angioedema. Paroxysmal nocturnal hemoglobinuria. This is important as well. They ask a lot about this. A defect in PIGA gene prevents the formation of glycosyl phosphatidylse inositol anchors for complement inhibitors such as decaying accelerating factors, DEF, CD55, and membrane inhibitor of reactive lysis, that's CD59. Causes complement-mediated intravascular hemolysis, decrease in haptoglobin and dark urine. It can cause atypical venous thrombosis, Budd-Chiari syndrome, portal vein, cerebral, or dermal thrombosis. The question here is going to be that the patient is young, he voided himself in the washroom and forgot to flush, and then the parents the next morning saw and the urine was dark red color. Then they're going to ask you what is impaired or what is the deficiency of in this patient. Then it's going to be CD55 or CD59. They're going to list all the CDs, but it's these ones. It's because at night, if you don't have CD59 or CD55, these are the things, remember, that prevents auto or self activation, right? So it prevents complement activation on self cells. And why is it red? It's because hemolysis causes leakage of bilirubin, which when left alone, causes darkening of urine. It can cause Budd-Chiari syndrome, portal vein, cerebral, or dermal thrombosis. Okay, now we're on important cytokines. Acute cytokines are interleukin-1, 6, TNF-alpha, which then recruit interleukin-8 and interleukin-12. So already went over that here. Interleukin-1, 6, and interferon alpha. They recruit interleukin-8 and 12. So let's do this one first because this helps tie everything together. Interleukin-1, 2, 3, 4, 5, and 6. So 6 of them. It's known for hot, like the mnemonic is hot T-bone steak. Right? So hot is interleukin-1, which is for fever. Then you have T for T cell, stimulates T cell, interleukin-2. Then you have bone for bone marrow. So interleukin-3 stimulates bone marrow. Then you have ST for nothing. And then you have E, A, and K, the last 3 letters. E is for interleukin-4, stimulates immunoglobulin E production. Okay, so interleukin E production. Interleukin-5 stimulates interleukin-A production, and interleukin-6 stimulates acute phase reactant or acute phase protein production. I actually have notes on this in my book. I'd like to go over it, so let me send it to myself first. Okay, so classical pathway is C1 complex, C1 QRS. Let me get that as well. Okay. So classical C1 complex C1 QRS forms on the Fc portion of an IgN or IgG, a antibody that is bound to antigen. Complex clears C4 plus C2 into C3 convertase. Okay. Uh, then you have alternate pathway. That small amount of auto-activated C3b continually forms and is inactivated by healthy cells. However, the presence of microbes or damaged cells amplifies the production of C3b, which then engages with factor B and factor D and generates C3 convertase. For lectin, loss pattern recognition receptors bind to carbohydrates that are produced only by foreign pathogens. Binding generates proteases that cleave C4 and C2 into C3 convertase without requiring C1 complex. Okay. Decrease in C3 and C4 and normal factor B. Okay, so if you have decrease in C3 and C4, but a normal factor B, okay, so this is what I was talking about, the question. Uh, Classical pathway via immunoglobulin G and antigen complex formation. That's what it would be. So if you have decrease in C3 and C4, that means it's going down here, but you have a factor B. So it's not going to be your alternative because this is normal amount. So it's not being used up. This is the thing that's being used up. So it's going to be classical pathway that's activated. Okay, hopefully that helped. Uh, close this, close this, finish that. Okay, back to this. So we did hot T-bone steak. Now, KS4 stimulates acute phase production, protein production. So, there's something about this as well. So I have a chart that says PIGA goes into GPI, so that's PIGA gene goes into GPI, and GPI is uh, what complement inhibitor. Okay, so that anchors for complement inhibitors such as decaying this. Okay, so this is what that does, GPI. And it's also a membrane inhibitor for reactive lysis. Okay, so it's nothing new. It's given in case. Uh, Important cytokines secreted by macrophages, interleukin-1, for the third time. It causes fever, acute inflammation, activates endothelium to express adhesion molecules, induces chemokine secretion to recruit WBC, also called osteoclastic activating factor. Uh, this thing is important because you're gonna look for other stuff like NFK, or NF kappa B cells and stuff like that, and like calcium and all that. But you're gonna forget about interleukin 1 also activates this, or PTH, right? So remember that. Also remember that it's the one that causes fever and acute inflammation, right? So that's for hot. Activates endothelium to express adhesion molecule, induces chemokine secretion to recruit WBC. Uh, I'm gonna drink water. Interleukin 6, it causes fever and stimulates production of acute phase proteins. So that's your acute phase protein right there. Then you have tumor necrosis factor alpha, activates endothelium, causes WBC recruitment and vascular leak. It causes cachexia in malignancy. If you don't know what cachexia is, we'll look that up. It's just the thing that causes weakness and fragile stuff. So weakness and wasting of the body due to severe chronic illness, right? So that's cachexia. So there's a question on that. They'll ask about a patient who's feeling weak after being sick for a long time. Which one of these is responsible for it? So it's going to be tumor necrosis factor A or alpha. Maintains granulomas in tuberculosis. Interleukin 1, 6, TNF alpha can mediate fever and sepsis. So all these three can mediate fever and sepsis, right? What does it do? It activates endothelium, causes WBC recruitment and vascular leak. Interleukin 8, it's a major chemotactic factor for neutrophils. Clean up on IL-8. It's important. Major chemotactic factor for neutrophils. So clean up on IL-8. Neutrophils are recruited by IL-8 to clear infection. This is important. IL-8 is the thing that recruits neutrophils. Interleukin 12 induces differentiation of T cells into Th1 cells. Right? So you have Th cells, that's interleukin 12, recruits that. Remember we talked about hot T, so T was interleukin 2, so that's there as well. And also here, and here. Okay. For induces neutropenic or philic inflammation is these. But don't forget about interleukin 8. So interleukin 12 induces differentiation of T cells into Th1 cell, activates NK cells as well. Okay, so there should be a line going here, and it should say interleukin 12 there. Facilitates granuloma formation in tuberculosis. So that's why it's major as well, because TB, as you know, you don't clear it off, your system doesn't clear it off, it walls it off. So how does it wall it off? It's this thing responsible for that, interleukin 12. Secreted by T cells. So these ones were secreted by macrophages, 1, 6 TNF alpha, and interleukin 8 and 12. These things recruit this. I have 12 here, but okay. So these ones are secreted by T cells. T cells secrete interleukin 2 and 3. So that's your T bone. T is stimulates growth of helper, cytotoxic, and regulatory T cells and NK cells. Interleukin-3 is supports growth and differentiation of bone marrow stem cells. Functions like growth GM-CSF5. What was GM-CSF? Colony stimulating factor, right? Granulocyte macrophage. Granulocyte macrophage colony stimulating factor. It functions like that. So it supports growth and differentiation of bone marrow stem cells. From Th1 cells, that's this one right here, you get interferon alpha, gamma. Interferon gamma secreted by NK cells and T cells in response to antigen or interleukin-12. From macrophages, stimulates macrophages to kill phagocytized pathogens, inhibits differentiation of Th2 cells, induces immunoglobulin G isotype switching in B cells as well. So its function is increases MHC expression and antigen presentation by all cells, activates macrophages to induce granuloma formation. This is the most important thing out of all of it right here. It activates macrophages to induce granuloma formation. We already know that it recruits all of this. Over here, it recruits cytotoxic T cell, macrophages, Th1, right? So that's okay. But the important one is activates macrophages to induce granuloma formation. So now we're going to talk about Th2 cells. Th2 cell right here, that's your humoral immunity. Interleukin 4, 5, 4 was so hot T bone as T E, so that's going to be your E, and then this is going to be your A, and then K is already done, number 6. Induces differentiation of T cells into Th helper 2 cells, promotes growth of B cells, enhances glass switching to immunoglobulin E and immunoglobulin G. Right? So it promotes B cell, enhances glass from E to G and G. Okay, E and G both. Not too important. Don't worry about it too much. Interleukin 5 promotes growth and differentiation of B cells, enhances class switching to immunoglobulin A, stimulates growth and differentiation of eosinophil. This is important. 5 is known for eosinophil. We have it here too, right there, for eosinophil by Th2. Then you have interleukin 10. That's important because it's anti-inflammatory. It attenuates inflammatory response, decreases expression of MHC class 2 and Th1 cytokines, inhibits activated macrophages and dendritic cells, also secreted by regulatory T cells. Okay. And then you have, so TGF beta and interleukin 10, they both are anti-inflammatory. Interleukin 13, it promotes immunoglobulin E production by B cells, induces alternative macrophage activation as well. Okay, so interleukin 13 promotes immunoglobulin E, like that. Cool. The important ones are these right here, and these right here, and these right here, and just know that interleukin 5 does growth and differentiation for eosinophils. Recipe burst, also called oxidative bursts, involves the activation of the phagocyte NADPH oxidase complex, for example, in neutrophil monocytes, and which, sorry, uh, I'm going to drink water. Hold on. Okay. So RESV burst, also called oxidative burst, involves the activation of the phagocyte NADPH. NADPH we get from HMP shunt oxidase complex. For example, in neutrophils monocytes, uh, they make it. Uh, sorry, they use it. They phagocyte NADPH uh, uh, phagocytes that have NADPH oxidase complex. These are in your neutrophils and monocytes. They utilize O2 as a substrate. We went over this yesterday in biochem when we're doing the glutathione one. It plays an important role in the immune response, uh, which has rapid release of reactive oxygen species. Okay. Then you have NADPH play a role in both the creation and neutralization for ROS, or reactive oxygen species. Myeloperoxidase containing a blue-green heme-containing pigment that gives sputum its color. So myeloperoxidase is what gives the green color to your sputum when you're sick from something that has this ROS. Okay, so they do ask you that. Uh, what makes the green color in your sputum? It's going to be your myeloperoxidase. Okay, so it utilizes O2 as a substrate, so you have O2 here. Then with uh, NADPH added to it, it becomes superoxide uh, with the help of that NADPH oxidase. So a deficiency of this is what's called chronic granulomatous disease. So you're just gonna have stuff around the causing causative, so it could be bacteria or whatever. So you're gonna have granulomas instead of destroying it and moving on. You're just gonna have granulomas everywhere. So that's what this is. It happens when you don't have any DPH oxidase, so this doesn't happen. The oxidative burst. Okay. Number two. So number two is superoxide dismutase. It takes the superoxide and makes it into H2O2. H2O2 then, if there's catalase, it goes and on and makes water molecule and O2 via bacterial catalase. So there are bacteria that are catalase positive. Uh, I think it's Staph aureus, and I don't remember the others. I'm trying to think of it. Hold on, give me a second. Nocardia is a catalase positive, okay. And as epidermidis is also. So Staph aureus as epidermidis is found on your skin. So that 10 minutes left. Okay, I'll. I don't think we'll finish, but okay. H2O. So that. So when you have bacteria that have catalase, so that's your Staph aureus or Staph epidermidis or nocardia, something like that. It's mostly going to be Staph aureus though. It could be Staph epidermidis, but that it that's what they're going to ask you about when they're asking about this. Uh, it's going to go there, or it could go the other way into reducing glutathione. uh, that's reduced glutathione into this, this, or with the help of chlorine or chloride, it's gonna become bleach uh, in the presence of myeloperoxidase. Right? We already went through reduction of glutathione yesterday, so I'll just quickly go over that. For catalase, glutathione peroxidase, glutathione reductase, and you have glucose 6-phosphate dehydrogenase. Okay. Uh, Bleach is also known as hypochlorite. Phagocytes of patients with chronic granulomatous disease can utilize H2O2 generated by invading organisms and convert it to ROS. Patients are at increased risk of infections with catalase positive species. For example, Asorius aspergillus. Okay, there you go. They give you the examples. Capable of neutralizing their own H2O2. Okay, so when you have this and the bacteria have their own catalase, they're just gonna make hydrogen peroxide into this, right? So H2O2 without ROS for fighting infection. Um, Piocyanin or Pseudomonas aeruginosa generates ROS to kill competing pathogens. Okay, so when you put this on a culture or something, it's going to generate this to kill off other pathogens uh, or even in the body. Oxidative burst leads to release of lysosomal enzymes. Lactoferrin is a protein found in uh, secretory fluids and neutrophils that inhibits microbial growth via iron chelation. So lactoferrin is a protein found in this and neutrophils that inhibit microbial growth via iron chelation. That's how it functions. For this, know about NADPH oxidase, know about superoxide dismutase, know about myeloperoxidase. They'll give you this diagram straight out, and then they'll ask you what enzyme is here, what enzyme is here or here. What makes this? So it would be catalase like that. For this one, they just want you to know that it only happens if you have this NADPH, right? Because you need that here, and it comes from HMP show. I'll stop here. We're doing now interference. Interferons alpha, beta, and gamma. The mechanism is it's a part of innate host defense. Interferons interfere with both RNA and DNA viruses. Okay, so interferons interfere with both RNA and DNA viruses. Cells infected with a virus synthesize these glycoproteins, which act on local cells, priming them for viral defense by downregulating protein synthesis to resist potential viral replication and by upregulating MHC expression to facilitate recognition of infected cells. Also play a major role in activating anti-tumor immunity. Okay. So you have, okay, we'll read this. Viral infection, interferon A and B or beta. They both do what? They halt protein synthesis, such as RNase and protein kinase R. These only activate in presence of double-stranded RNA, which only forms in infected cells as a result of viral replication. Okay, so remember, interferon alpha and beta are for viral infection. Uh, So it's similar to what this is saying, it's just more specific. Clinical use for chronic uh, hepatitis B virus, Kaposi sarcoma, that's herpes virus 8, uh, hairy cell leukemia, condyloma acuminatum, uh, that is uh, syphilis, I think, right? RCC, malignant melanoma, MS, and chronic granulomatous disease. So you can use this for all of these, right? Adverse effects, flu-like symptoms, depression, neutropenia, myopathy, interferon-induced autoimmunity. Flu-like symptoms, depression, neutropenia, myopathy, interferon-induced autoimmunity. Okay. So I wrote this because there was a question about it, and they were questioning about how does this work? Like, how do these interferons work? Because we already know about this one. It uh, recruits macrophages, right? Interferon gamma. It recruits cytotoxic T cells, but we don't know much about these. It's because, well, right here, it halts protein synthesis, such as RNAs and protein kinase R, and they activate in presence of double-stranded RNA. That is important as well, which only forms in infected cells as a result of viral replication. Okay. Surface markers or surface proteins, cell surface proteins, T cells. T cells have TCRs on it, CD3 and 28, so it binds to B7. B7, also known as CD80 and 86, it's on B cells, so you'll find it in B cells, CD80 and 86. You need to know markers, like especially these ones, because you'll find that in HIV. Helper T cells are CD4 and CD40L. Remember, the ligand is on T cells, and the CD40 is on macrophages and on B cells, right? So this will attach to B cells and macrophages, because macrophages is also antigen presenting cell, right? So we did CD4, 40, CXCR4, and CCR5. This one is tested on. You'll remember this or this, but you won't remember both of them. And they'll ask one or the other when the question comes. So remember them both. Cytotoxic T cell, we already know that. CD8 is the cytotoxic T cell. Regulatory T cell, that's your CD4 and CD25 Treg, right? So it has CD4 and that CD25. CD3 is found on almost all T cells, so you see it here, but its majority of it is like on everything. So that's why it's here in T cell, CD3, right there. You'll find it in all the T cells, mostly. B cells, immunoglobulin binds antigen. You have CD19, 20, and 21. They are important for Epstein-Barr. So 21 is important for Epstein-Barr. So they'll say the infection detected CD21. What kind of infection is it? It's Epstein-Barr virus. You have CD40, MHC2, and B7. Right. B7 is CD80 and 86. NK cell, CD16. You already know that CD16 and 56 on NK cells. Suggestive marker for NK cell. Okay. Macrophages. CD14, receptor for PEPs. For example, LPS. You have CD40. You have CCR5, MHC2, B7, and FC and C3b receptors. They enhance phagocytosis. Remember CD14, that's the one they're going to test you on. CD40 is pretty easy to remember. CCR5 is found on this as well. Like they'll tell you the receptors are found, but it's negative for T cells, so what is it? And then you're not going to remember that it's also on macrophages because you're going to think about something to do with HIV, maybe the cells destroy something, but no, it's on macrophages, so that's what it is. Hematopoietic cells or stem cells are CD34. That's okay. Remember the markers for T cell, B cells, and macrophages. NK is easy to remember. CD's 16 and 56. Energy. What is energy? It's a state during which a cell cannot become activated by exposure to its antigen. T and B cells become anergic when exposed to their antigen without costimulatory signal. 2. Another mechanism of self-tolerance. So basically, over here, where'd it go? Right here. The two signals are this and this. So say one of them is joined, but the other one isn't. Then you get energy. Energy. This thing. There's a question on this as well. Give me a second. Okay, it's not on this. It comes after, so do it then. So yeah, it's state during which a cell cannot become activated by exposure to its antigen. T and B cells become anergic when exposed to their antigen without the second signal. Another mechanism of self-tolerance. Passive versus active immunity. They do test you on this, so know what it means. Right? Passive and active immunity. So what is passive immunity? And what is active? Means of acquisition of passive is receiving preformed antibodies. So that would be like your snake venom ones, I guess, right? Or antibodies to one of the toxins. Active is when you're exposed to the exogenous antigens. Onset is rapid in passive because you're bypassing the whole process of making antibodies. And active is slow. Duration, short span of antibodies, half-life equals 3 weeks. Okay, so they only last for until the antibodies last because you don't make new ones, so it's a short span of antibodies. Active ones are long-lasting protection because there's a memory. Example of passive would be IgA and breast milk, okay, and maternal immunoglobulin G crossing placenta, because IgG greets the newborn fetus or whatever. Antitoxin and okay, there you go. I wasn't wrong. Antitoxin. Humanized monoclonal antibody. Okay. What about active? Natural infection, vaccines, and toxoids. Okay. So that's like your tetanus ones. No. In passive, after exposure to tetanus toxin. Okay. So I guess this is your passive. Hmm. Uh, Hepatitis B virus, varicella, rabies virus, botulinum toxin, or diphtheria toxin. Unvaccinated patients are given preformed antibodies. Passive. Okay. Oh, okay. So they're talking about after they are exposed to it. Okay. Never mind. They're given, if they weren't vaccinated, they would be given preformed antibodies. So this is your passive one. An active, combined passive and active immunization. So they give preformed and this uh, active immunization. It can be given for Hep B or rabies exposure. Vaccination. It induces an active immune response, humoral or uh, to specific pathogens. Okay, I have a mnemonic for this. Was I can't recall now. Gonna have to go look into my notes for that. But okay, let's just get through it. Induces an active immune response, humoral or cellular to specific pathogens. Live attenuated vaccine, microorganism rendered non-pathogenic but retains capacity for transient growth within inoculated host. MMR and varicella vaccines can be given to people living with HIV without evidence of immunity if CD4 cell count is more than 200 cells. Okay, so pros: it induces cellular and humoral responses, induces strong, often lifelong immunity. But cons are that it may revert to virulent form. So it's contraindicated in pregnancy and patients with immunodeficiency. Examples are adenovirus, not attenuated, given to military recruits. You have typhoid uh, for oral. Uh, then you have polio, 7, uh, varicella, that's chickenpox, smallpox, BCG, yellow fever, influenza, intranasal, this one, MMR, and rotavirus. Then you have killed or inactivated vaccine. Pathogens is inactivated by heat or chemical, maintaining epitope structure on surface antigens is important for immune response, mainly induces a humoral response. And the pro is that it's safer than live vaccine, but cons are weaker cell-mediated immune response, booster shots usually needed. Hepatitis A, typhoid, V, polysaccharide, intramuscular. Rabies, influenza, intramuscular, and polio, Salk. Okay, so you have Hep A, typhoid. This is intramuscular one. This one was oral and live. You have rabies. Uh, don't mix that with your rubella and rota. Influenza and polio. So the polio was Sabin here. This is Salk. Uh, Subunit recombinant polysaccharide and conjugate. They test you on this one. So this is important. All use specific antigens that best stimulate the immune system. Pro is that it targets specific epitopes of antigen. So there are lower chances of adverse reaction. Cons is that it's expensive and weaker immune response you get. Okay. Uh, it can be given, right, for Hep B. So antigen equals hepatitis B surface antigen, uh, herpes virus, or human papilloma virus. Uh, HPV is papilloma, right? Or is it herpes? Yeah, papilloma. But now I have to check anyways. Human papilloma virus, yes, okay. So what? Okay, they spell out herpes. Okay. HPV. Acellular pertussis, AP. Neisseria meningitis, various strains. Streptococcus pneumonia. That's PSV23 polysaccharide, primarily T cell independent response. PCV13 conjugated polysaccharide produces T cell dependent response. Okay, so when it's by itself, it's gonna give you a T cell independent response, but then when you conjugate it, it's gonna give you a T cell dependent response, which is better than without it, right? So they're gonna ask you, why do you do this? It's so that you get T cell dependent response, right? H. influenza type B and herpes zoster. Toxoid, denatured bacterial toxin with an intact receptor binding site, stimulates immune system to make antibodies without potential for causing disease. Pros is it protects against the bacterial toxins. Cons is that antitoxin level decrease with time, thus booster shots may be needed. Uh, these are for your Clostridium tetani or Corynebacterium diphtheria. Or straight out, we can just give mRNA and it will work. That's what we do for COVID, right? Lipid nanoparticle delivers mRNA, causing cells to synthesize foreign protein, for example, spike protein of SARS-CoV-2. Induces cellular and humoral immunity. Pros is high efficiency, safe in pregnancy. However, the cons is that it's local and transient systemic. Fatigue, headache, myalgia reactions are common. Rare is myocarditis, pericarditis, particularly in young males, given in SARS-CoV-2. Okay, now we are on hypersensitivity types. There are four types: A, B, C, D. A is for anaphylactic and atopic. So that's your allergic ones as well as anaphylaxis. Uh, so the way I remember is that anaphylaxis ones are the reactions are the ones where you would use the EpiPen. So if it's something that would require that or something that would require the pump, it's going to be type 1 because it's usually it gets confusing between type 1 and type 4 in the examples, right? So even though this is only cell media and this is humoral. You have antibody mediated type 2 and then immune complex type 3, that's the serum sickness one, and or delayed cell mediated type 4. So you have type 1, 2, and 3, which are all antibody mediated. All right. So type 1, you have an allergen attached to a Ig, which is attached to the Fc receptor of immunoglobulin E, right? Okay. And then you have degranulation stuff coming out. Okay. Anaphylactic and atopic, two phases. Immediate is that means minutes. Antigen cross-links preformed immunoglobulin E on pre-sensitized mast cells. This leads to immediate degranulation, which which causes release of histamine, a vasoactive amine, tryptase, a marker of mast cell activation, and leukotrienes. Okay, so you remember tryptase, that's the important one. You're gonna remember histamine because that's related to atopy, right? But you're not gonna remember tryptase. It's also a marker for mast cell activation. And leukotrienes, they don't give you that in the option. They give you tryptase though. So tryptase type 1, anaphylactic, atopic, IgE, just remember that. Late is in hours, not days, just hours. Chemokines attract inflammatory cells, for example, eosinophils, and other mediators from mast cells. So this leads to inflammation and tissue damage. First type and fast. So it's first and fast. Fast and furious. I wonder if you know. Test, skin test or blood test, ELISA, for allergen-specific immunoglobulin E. Examples are anaphylaxis of food, uh, drug, or bee sting allergies, right? Or you can have allergic asthma. But you're not going to, so when I say this, that you use EpiPen, you're not going to use EpiPen for uh, what? Your, say, poison ivy, right? Or nickel, nickel, basically, causing rash on your skin. You're not going to use that stuff. So that stuff is going to be your type 4 hypersensitivity. Oh, there you go. Poison ivy or nickel allergy, right? Or graft versus host disease. You're not going to give epi for that. So don't confuse this, just so you don't confuse type 1 with type 4. Uh, okay, so hopefully the mechanism is clear. If not, what happens is when allergen binds to the uh, entropy site on the immunoglobulin, it doesn't just bind to one, it binds to several of them. So several of them attach then to the Fc receptors. So the more Fc receptors get uh, together, it's going to pull on the surface, and that's what causes the degranulation. So one or two is not going to cause degranulation. It's when it's attached to many Fc receptors, that's when degranulation happens. Uh, Type 2 hypersensitivity. Antibody bind to self-surface antigens or extracellular matrix, cellular destruction, inflammation, and cellular dysfunction. Uh, Antibodies bind to cell surface antigens or extracellular matrix, cellular destruction, inflammation, and cellular dysfunction. My brain's not registering this. Okay. So antibodies bind to self-surface antigens. Okay. Right. So it binds to cell surface antigen. Okay. Or extracellular matrix. Got it. Which leads to cellular destruction. Okay. And inflammation and cellular dysfunction. Okay. So you have an NK cell here. You have Fc receptor for IgG. You have surface antigens attached to it in the atopic site. Abnormal cells and antibody-dependent cellular cytotoxic is happening now. Okay. Cellular destruction. Cell is opsonized or coated by antibodies, leading to either phagocytosis and or activation of complement system, or NK cell killing. Antibody-dependent cellular cytotoxicity. Right. Inflammation. Binding of antibodies to cell surface leads to activation of complement system and Fc receptor mediated inflammation. Cellular dysfunction. Antibodies bind to cell surface receptors that leads to abnormal blockade or activation of downstream process. Cellular dysfunction. Antibodies bind to cell surface receptors. This leads to abnormal blockade of activation of downstream process. Right. So once it gets attached, whatever the function of that cell is, it's not going to work once antibodies are attached to it. Right. That's what it means. Okay. Derek-Coombe test detects antibodies attached directly to RBC surface. Let's look that up. So you have blood sample is taken from a patient with hemolytic anemia and antibodies attached to red blood cells. Then a few drops of Coombe reagent containing anti-human antibodies is mixed in with the patient's blood sample. Then agglutination happens, right? So these are antibodies against the antibodies of these, right? So that's what causes the agglutination in direct. In indirect, you have patient's serum containing antibodies is drawn, donor blood is added, you have patient's antibodies bind to donors, you have a few drops of Combs reagent are mixed with the sample, and then you have agglutination reaction as observed. Okay. So Derek-Coombe test detects antibodies attached directly to the RBC surfaces, whereas in indirect, it detects presence of unbound antibodies in the serum. So for cellular destruction, the examples are uh, autoimmune hemolytic anemia, including drug-induced form, immune thrombocytopenia, transfusion reaction, or hemolytic disease of the newborn. For inflammation, the binding of antibodies to cell surface that activates the complement system Fc receptor. This would be your Goodpasture syndrome, rheumatic fever, or hyperacute transplant rejection. And cellular dysfunction is antibodies binds to the cell surface and stops the function of it. This would be your myasthenia gravis, Graves' disease, and pemphigus vulgaris. Okay, so for these, they'll give you these. Uh, presentation will be of these things right here, and then there will be like what other disease is similar to this one. So if it's Goodpasture, then another disease that's similar to it is rheumatic fever, because they both are type 2 hypersensitive reaction, right? Similarly, they would give you like transfusion reaction, you'll figure it out, and then in the thing they'll give you, is it similar to this or is it similar to, something else that's not listed here. So it could be like that too. Like they will list out all this stuff and then they'll give you example of type 2, type 3, type 4, type 1. They do that a lot with type 4 because it's uh, cell mediated and not humoral. Type 3 hypersensitivity. This is immune complex. So antigen antibody, the complex it makes when it attaches to it, mostly immunoglobulin G complex, activates complement, which attracts neutrophils, and then neutrophils release lysosomal enzymes. Okay, so this is normal antigen antibody. What's not normal is when it gets deposited in tissues, because that's how you get rheumatic arthritis or SLE or reactive arthritis. What happens is when it settles in like joints and stuff, then around it, it's going to attract neutrophils, and the neutrophils are going to release enzymes and cause symptoms there. That's why type 3, or that's how it happens. It can be associated with vasculitis and systemic manifestations. In type 3 reaction, imagine an immune complex as three things stuck together: antigen, antibody, and complement. So these complex activates complement which recruits neutrophils. Examples are SLE, rheumatoid arthritis, reactive arthritis, polyarthritis nodosa, or also known as PEN. It's a vasculitis. It's the one with the pearl and bead appearance of the artery. Post-streptococcal glomerulonephritis, and IgA vasculitis. Okay. Fever, urticaria, arthralgia, proteinuria, lymphadenopathy occurs 1 to 2 weeks after antigen exposure. Serum sickness-like reactions are associated with some drugs, may act as hapten, for example, penicillin, monoclonal antibodies, and infections, for example, hepatitis B. Serum sickness, the prototypic immune complex disease. Antibodies to foreign proteins are produced, right? And 1 to 2 weeks later, antibody-antigen complexes form and deposit in the tissue. So you have complement activation there and inflammation and tissue damage there, right? So a question will say that the patient he was sick, and then he was treated and all the symptoms were gone. But then 2 weeks later, he comes back with joint pains. That's a classic presentation for sickness, right? Uh, so they're going to ask you, what is it? It's a type 3 hypersensitivity. That's what it is. Uh, or what's causing it? It's the complement activation around the tissue that's causing the damage, that's doing the symptoms. Okay. Then you have Arthur's reaction, a local subacute immune complex mediated hypersensitivity reaction, intradermal injection of antigen into a pre-sensitized uh, individual which has circulating immunoglobulin G, leads to immune complex formation in the skin. For example, enhanced local reaction to a booster vaccination, characterized by edema, fibrinoid necrosis, and activation of complement. Give me I'm going to read that again. A local subacute immune complex mediated hypersensitivity reaction. Intradermal injection of antigen into a pre-sensitized or has this individual leads to immune complex formation in the skin. So I guess that's like your enhanced local reaction to a booster vaccination. Okay, that or tuberculin, I guess, because it would have this, right? That's how you check if someone has TB or not. Characterized by edema. Wait, no, TB is type 4 though, so that's not it. Okay, so I guess this is the example for that. I'm not too sure how they would test you on this, so just look out for that. Characterized by edema, fibrinoid necrosis, activation of complements. Okay. Type 4 sensitivity, hypersensitivity. So you have antigen presenting cells, antigen over here, sensitized T1 cell, cytokines, activated macrophages, and delayed. This is called the delayed type hypersensitivity. Okay. So there are two mechanisms, each involving T cells. Uh, Number one is direct cell cytotoxicity. So CD8, wait, yeah. CD8 cytotoxic T cells kill targeted cells, or it could happen like this: inflammatory reaction. Effector CD4 plus T cells recognize antigen and release inflammation-inducing cytokines, shown in the illustration. Okay, effector CD4. So there's the activated macrophages. This is the antigen presenting cell. It came in with its antigen. The T cells is now doing its thing, and then it's going to recruit via interferon, gamma, and interleukin 2, the macrophages. Right, so CD4 to recognize antigen and release inflammation-inducing cytokines shown in an illustration. Or it can directly call CD8, right? It can go here, and this will directly call CD8 right there. Same thing, interferon, gamma, and interleukin 2. Response does not involve antibodies versus type 1, 2, and 3. Uh, Examples are contact dermatitis, for example, poison ivy, nickel allergy, right? This is still an allergy, right? So don't confuse that nickel allergy with, you know, allergy of something that, you know, food or drug or bee sting. These things don't require you to, if you see someone going in an anaphylactic shock because of food, their epiglottis is going to swell up, like their throat swells up, so they need the EpiPen, or penicillin will give you like petechiae or reaction all over the body, something like that. They're going to need it. Bee sting, almost everyone knows about this, so that's going to need it. But you're not going to need it for allergy to nickel, right? So they're going to give you various examples and questions. So far this has worked for me, thinking it this way. Graft versus host disease. This is type 4. Remember that. I think we'll go over it. Test PPD for TB infection, patch test for contact dermatitis, candida skin test for T cells, immune function. Okay, so all the skin tests like that is type 4 hypersensitivity. So when they're talking about patch test for contact dermatitis, remember it's this. And then, 4 T's: T cell, transplant rejection, TB, skin test, and touching or contact dermatitis. 4 type and last and delayed. Okay, I'm gonna take was Rome is my best place to go. ROME was rubella, OPV, mumps, endemic typhus, influenza, M for measles, BEST is for BCG, place is plague, and T for typhoid vaccine for typhoid. So these were the important live vaccines that you need to know about. Immunologic blood transfusion reactions are allergic type, pathogenesis, timing. We're going to do clinical presentation, donor blood, and host blood. Allergic, anaphylactic, and reaction. Allergic anaphylactic reactions. This is your type 1 hypersensitive reaction against plasma proteins and transfused blood. Okay, so that was allergic anaphylactic reaction, type 1 hypersensitivity reaction against plasma proteins in transfused blood. So that's just that. IgA deficient individuals should receive blood products without IgA. This is important. They test you on that. Timing within minutes to 2 to 3 hours due to release of preformed inflammatory mediators and degranulating mast cells. Classic presentation is allergies. It's going to look like that. You're going to have urticaria, you're going to have pruritus, that's just itching, anaphylaxis, so there's wheezing. When there's wheezing, you know it's going to be something like this, anaphylaxis or allergy, or there's wheezing and asthma as well, or asthma. So anaphylaxis is wheezing, hypotension, respiratory arrest, and shock. Right, so you have donor blood with plasma cells in it, plasma proteins, and donor plasma protein, including IgA. Okay, and you have host blood that is already sensitized to, or if not, then it will be. So it has anti-immunoglobulin A, right? Because they're IgA deficient individual. So when you give a blood sample with IgA to a person who is IgA deficient, there's going to be a allergic shock or anaphylactic shock. Right? You got host mast cell. This happens in 2 to 3 hours. This is the only one that's this fast. None of the other ones are going to be this fast. If they are, it's going to be this one. Yeah. And they will give you wheezing, at least. So you know it's this. Acute hemolytic transfusion reaction. Okay, so that's type 2 hypersensitivity reaction. Typically causes intravascular hemolysis. That's ABO blood group incompatibility, right? So you donate blood from a type A to type B, and then you get acute hemolytic transfusion reaction during transfusion or within 24 hours. So it can be from anywhere to anywhere. It's due to preformed antibodies. They will give you the history, right? So why it's happening to the person. So if they say that he was given blood, it's going to be one of these, then you just gotta differentiate between these. So this one, you're going to have flank pain as your buzzword, like wheezing was for this one. So fever, hypertension, that's all vague because you get that here too. Tachypnea, tachycardia, flank pain. That's the buzzword, but it goes along with this as well. Hemoglobinuria. So that's when you know that there's hemolytic anemia, right? Because now you're having hemoglobin in your urine. Intravascular and jaundice is because of extravascular causes. Then you have febrile non-hemolytic transfusion reaction. That's cytokines created by donor WBC accumulate during storage of blood products. Reactions prevented by leukoreduction of blood products. Okay, so In this one, you're gonna have flushing. That's gonna be your buzzword. Febrile, so that's fever, but fever happens in this one too. But this one has these two things. Right? This is not hemolytic, so you won't have hemoglobinuria. Cytokines created by donor WBCs accumulate during storage of blood products. So when you have blood product that's stored away, it's going to create WBCs, right? And that's the one, because initially it's going to be washed out, but then when it's stored, it's going to make more. So that's going to attack the host. The reactions can be prevented by leukoreduction of the blood product. That's just fancy way of saying getting rid of WBC from the blood. Again, this happens within 1 to 6 hours due to preformed cytokines. So the timing is not going to be that helpful, I guess, because it's overlapping. What is going to be helpful are the buzzwords. So you have fever, then you have febrile. If you have chills, that's febrile as well. You have flushing, that's your non-hemolytic transfusion reaction. It's more common in children, so look out for the age as well. For acute hemolytic, you have flank pain, you have hemoglobinuria. That tells you right away that it's hemolytic, right? There is a delayed hemolytic as well, so we'll do that when we get there. So yeah, you have flushing in this, and it happens in children. They might just ask you. They might even give you that this person is having reaction from a blood product. Uh, what could it be? They were matching the blood types and everything, but he's still having reaction. It's going to be this one. On transfusion-related acute lung injury, two-hit mechanism. Uh, so neutrophils are sequestered and primed in the pulmonary vasculature due to recipient risk factors. So because of that, like smoking or whatever, there were already neutrophils here. So then neutrophils are activated by a product, for example, anti-leukocyte antibodies in the transfused blood, and release inflammatory mediators. Uh, yeah. Okay. In the transfused blood and release inflammatory mediators, which causes increase in capillary permeability, which leads to pulmonary edema. Inflammation around anything, and neutrophils itself, they cause increased permeability. So over here, it's going to be capillary having increased permeability, which will cause pulmonary edema. That's how you get transfusion-related acute lung injury. So the question stands going to be like, the person was given blood, and now he's having difficulty in breathing, right? Because within 6 minutes to 6 hours, they have respiratory distress, and it's non-cardiogenic pulmonary edema. They're going to say the ECG is not showing any signs of distress, but this person is having hard time breathing. He was just given blood, so that's going to be a transfusion-related acute lung injury. It's because he was a smoker or something, or for any reason there were already neutrophils in the lungs, and now because of leukocytes in the body, in the blood product, uh, the neutrophils are getting activated in the lungs. Delayed hemolytic transfusion reaction. Uh, it's this one and this one that gets confusing. The acute one and the delayed one. Okay. So acute one happens during transfusion within 24 hours. And this one says onset is over 24 hours, but it's not that obvious in the question stem. Delayed hemolytic transfusion reaction. That's anemistic response to a foreign antigen on donor RBCs, RHD, or other minor blood group antigens previously encountered by recipient. So it's because of something that happened in the previous blood transfusion, right? So that's the cause for an antigen on donor RBCs, that's RHD or other minor blood group antigens. Typically, extravascular hemolysis. This is extravascular. Here it was intravascular. Right? This was because of ABO blood group incompatibility. This is because of something other than that. Onset is over 24 hours, usually present within 1 to 2 weeks due to slow destruction by reticuloendothelial system. Generally self-limited and clinically silent. Mild fever and hyperbilirubinemia. So generally self-limited and clinically silent. So that's why it's hard to figure out. And it's self-limited, so it's not that bad. Mild fever, so you would think febrile again. Okay. And hyperbilirubinemia. And that's it. So let's do an overview of that. For allergic and anaphylactic, you'll have wheezing. You'll have signs of allergies like pruritus and urticaria. Um, this one is, they might give you that, might not, because they save it for this question. Right? Anything to do with lungs. They'll say shock, so you know it's something bad. And they'll give you that the blood was transfused. In acute hemolytic transfusion reaction, it's because of ABO. You'll have flank pain and hemoglobinuria as the buzzwords. Don't focus on other stuff because fever is very vague. It happens here and here as well. Tachypnea happens in respiratory distress. Tachycardia can happen on other stuff. All of that is jaundice. They might give you jaundice, but that's very vague. It could be anything. You're not going to connect it to this. But this is what's going to connect it after transfusion to acute hemolytic transfusion reaction. For febrile non-hemolytic, it happens because of the WBC formed in a blood store while it's in storage. The best way to prevent this is just doing more washes. Here, the buzzword is flushing, and they'll give you fever. They might not give you chills and headache, but they'll give you flushing. And it's more common in children, so look out for the age. Oh yeah, and they tell you that it's because of transfusion, but the blood group were matching. It was compatible. So what else could it be? So then that's all that's left. Because they'll tell you that there's no hemoglobin in the urine as well. So it's not hemolytic. Transfusion-related acute lung injury. He might be a smoker or something, so he has neutrophils in the lungs. So when you give the blood with antigens, neutrophils get activated in the lungs and they do stuff there, which causes capillary permeability increase, and that will lead to edema. And the questions then will have respiratory distress after giving blood, difficulty in breathing. Delayed hemolytic transfusion reaction. This one you just do it by crossing out all the other ones. And if nothing else is there, then this is what's left. So that's what it is. Mostly that's how this one works. But they'll give you this hyperbilirubinemia. You don't get that in anywhere else. Uh, it's not that. It's very mild fever and it's clinically silent, so it's not lethal or anything. There's extravascular hemolysis for this. That's why you see hyperbilirubinemia. It happens because of anything other than ABO. Autoantibodies. This is something you just gotta memorize. Where by the end of FA, you'll just know all of these without memorization. So I'll just go over it once. Uh, so for myasthenia gravis, the autoantibodies are anti-postsynaptic acetylcholine receptors, right? For Lambert-Eaton myasthenic syndrome is the calcium one. So anti-presynaptic voltage-gated calcium channel. For antiphospholipid syndrome, this is when you have multiple miscarriages in a pregnant lady. She's gone through many miscarriages is because of this syndrome. The autoantibody here is anti-beta-2 glycoprotein 1. Non-specific screening antibody also often associated with SLE is ANA, anti-nuclear. Another one for SLE and antiphospholipid syndrome is anticardiolipin and lupus anticoagulant. Uh, I think it's this one that also tests positive for syphilis or VDRL actually. So look out for that. This one also tests positive for VDRL. SLE is anti-double-stranded DNA and anti-Smith as well, just by itself. Antihistone. So yeah, why this is important? It's because they'll say that they did a test and for VDRL and this was positive, but then when they did ELISA or something very specific, nothing got picked up. So why would this be positive? It's because it could be this, or vice versa. They tested for this was positive, but then when they did the test, this came back negative. So then why would this be? It's because they have venereal disease. Okay, so then you have drug-induced lupus, antihistone. Mixed connective tissue disease, anti-U1RNP ribonucleoprotein. Rheumatoid arthritis, rheumatoid factor, IgM, antibody against IgG, Fc region, anticyclic citrullinated peptide, or anti-CCP. This is the important one. Remember that. Rheumatoid factor is also important. It's IgM antibody against IgG Fc receptors region. But they'll give you this full form and you'll remember this short form and then you won't recall this. So remember both of it. Anti-cyclic citrullinated peptide. And this one is more specific. Sjogren's syndrome, that's anti-Ro. SS is easy, that's Sjogren's syndrome. Or anti-La, that's Sjogren's syndrome B. If you don't know what this looks like, let's look at it. They don't have it. But basically, it causes redness on the face. You have scleroderma, that's anti-SCL 70. That's anti-DNA topoisomerase 1. What does topoisomerase do? I believe it cuts the thing. So it doesn't supercoil. So then you have anti-SCL. Also, SCL is for scleroderma. Limited scleroderma, Crest syndrome. Sorry. Crest is calcinosis, Raynaud's phenomenon, esophageal dysmotility, S is for sclerotectily, and T is for telangiectasia. Okay. Anti-synthetase. These ones are important. Uh, know the short form, but also know the full form because they test you on the full forms. So for poliomyositis or dermatomyositis, that's when you have weakness in your hips and shoulders, I think. That's their presentation. It comes in muscular, a little bit there, but anti-synthetase, uh, for example, anti-Jo1, they ask about this. Anti-SRP, anti-helicase, and anti-Me Too. Okay. Uh, you have primary biliary cholangitis. The autoantibody here is anti-mitochondrial. This one is important too. Uh, autoimmune hepatitis, sorry, autoimmune hepatitis. The antibody here is anti-smooth muscle, anti-liver kidney, microsomal 1. Microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, ulcerative colitis, primary sclerosing cholangitis. Myeloperoxidase, anti-neutrophil cytoplasmic antibody. So that's your MPO-ANCA, perinuclear ANCA, and P-ANCA. All of these are important. They show up in vasculitis and renal. You have microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis. These were like your Wegener's and that stuff. Churg-Strauss and Wegener's, I think. So that'll cause this. Granulomatous with polyangiitis. Okay, maybe this one was that. Cienca is Wagner's, right? So this one is Wagner's because you pronounce it Wagner's, so with a C. So C will cause that, and the C goes, if you put a big C on a person, it goes through your nose, lungs, and kidney or something like that. What does that one do there? Primary membranous nephropathy is antiphospholipase A2 receptor. Bulbous pemphigoid is anti-hemidesmosome. Sorry. This one is important. They'll give you this, then you have to figure out what it is. It's bullous pemphigoid. When it's just not hemi, just the desmosome or desmoglein in this one. There you go, anti-desmosome. It's going to be pemphigus vulgaris. Hashimoto thyroiditis, anti-thyroglobulin, anti-thyroid peroxidase, antimicrosomal. Graves' disease is anti-TSH receptor. Celiac disease is IgA anti-endomysial or IgA anti-tissue transglutaminase, IgA and IgG demediated gliadin peptide. We'll do this in GIT. Type 1 diabetes mellitus. You have anti-glutamic acid decarboxylase, islet cell cytoplasmic antibodies. You have pernicious anemia. The antibodies for that is anti-parietal cells and anti-intrinsic factor. Goodpasture syndrome, that's the basement membrane one. Type 4 collagen. Anti-glomerular basement membrane. That's easy. Because pasture is like a ground, and ground has basement in it. Okay, immunodeficiencies. Fine. We're going to do disease, defect, presentation, and findings. So X-linked, if you remember that song that I did for X-linked in biochem, uh, Burton was in it. So Bruton, X-linked or Bruton A-gamma globulinemia. This is a B cell disorder. So defect in BTK, a tyrosine kinase gene that leads to no B cell maturation, X-linked recessive, and this is increased in boys. Uh, okay, so Bruton or A-gamma globulinemia. Actually, let's do it the other way. Let's see what the findings are going to be and then read the stuff. So here you have absent B cells in peripheral blood, decreased immunoglobulin G of all classes, right? Because all the immunoglobulins come from B cell. So if you don't have B cells, then how are you going to have this? So A means without gamma globulinemia, right? That makes sense. Absent and scanty lymph nodes and tonsils. Primary follicles and germinal centers are absent because that's where B cells are, in the follicles and germinal centers, right? So if there's no B cell, then there's no need for these. So they're going to be absent or scanty. This leads to, so because of this, live vaccines are contraindicated. The whole point of giving live vaccine is to make memory and, fight it while making the memory. So that's why it's contraindicated. So the presentation is going to be, you're going to have recurrent bacterial and enteroviral infection. So recurrent bacterial and enteroviral infection after 6 months. So um, it's okay till 6 months because the newborn is going to have maternal immunoglobulin G, but after 6 months it starts waning off, or it wanes off after 6 months, right? So that's when the recurrent bacterial infection is going to start, and enteroviral infection. This is basically what the presentation is going to be in question stem as well. They're going to say that the patient, but they're going to confuse you by saying that the newborn was breastfed until now, and now they stopped breastfeeding, and now they're having recurrent bacterial infection. So you're going to think it's about something about the milk, but no, it's because they stopped having maternal IgGs, and they can't fight the infection on their own. So why does this happen? This is A-gamma globulinemia, also known as Bruton, so B for BTK, a tyrosine kinase, right? So TK is for tyrosine kinase gene. So there is no B cell maturation. This is X-linked recessive, and it's increased in B for boys. Okay, so then you have selective IgA deficiency. IgA is important for GIT, so you can have GIT symptoms, I guess. First of all, the findings are decrease in IgA with normal IgG and IgM levels, but there is increased susceptibility to GRDSs. So they might even tell you that this person has GRDSs, or they might give you that they went camping and drank water there, and now they have diarrhea. So why is that? It's because they don't have IgA. Because you need a lot of GRDSs, contaminated water. You need to drink a lot of it to have the symptoms. It can cause false negative celiac disease test. Right, so even if they don't have celiac disease, if you test for it, it might give you positive ones, positive for that, and selective IgA deficiency. What the presentation is going to be is majority is going to be asymptomatic, because this is the most concerning in this. So if you don't go hiking and drink forest water. You're not going to have this. A majority asymptomatic, can see airway and GI infections, autoimmune disease, atopy, anaphylaxis to IgA in blood products. This is important. Like this one ties in with this one, allergic. Uh, they ask about that. That's what the presentation is usually. That the person was suffering from uh, airway and GI infections and they required blood, so they gave blood, and now the person's doing worse. It's because the blood had IgA in it. Okay. Defect is its cause is unknown. Most common primary immunodeficiency. Common variable immunodeficiency. So here you're gonna have decrease in plasma cells, and you're gonna have decrease in immunoglobulins. Right, so you don't have a variety of them because there is a defect in B cell differentiation. Cause is unknown in most cases. So presentation is going to be, it may present in childhood, but usually diagnosed after puberty. Increased risk of autoimmune disease, bronchiectasis, lymphoma, sinopulmonary infections. Yeah, so again, diseases and infections in childhood, but usually diagnosed after puberty. So that the person's going to be like 12 or 15 years old. There's increased risk of autoimmune disease, bronchiectasis, lymphoma, and sinopulmonary infection. Okay. They'll give you the lab findings are decrease in plasma cell and decrease in protein as well, or immunoglobulins, they might give you that too. So if there's decrease in plasma cells and decrease in this, that means something's wrong with B cell, right? And that one is called common variable immunodeficiency. If something is wrong with B cell, you only have three things. You have X-linked burden agammaglobulinemia, right? In that, you only have IgG, decreased hemoglobin of all classes. Never mind, it's all of them as well. Okay. Oh yeah, in this, the buzzword was that 6 months. It started after 6 months. So that's for this. So for this one, it's only IgA that's decreased. IgG and IgM is normal. So if it's not these two, it's going to be common variable immunodeficiency. So they're going to ask about the defect. So the defect is B cell differentiation. So it's easy to get that for B cell related disorders. T cell disorders, thymic aplasia. This is going to be your DeGeorge one. Okay, so you have 22q11 microdeletion, failure to develop third and fourth pharyngeal pouches, which leads to absent thymus and parathyroids. So this is important. It develops from third and fourth pharyngeal pouch. They ask about this. What do they develop? They develop thymus and parathyroids. That's where it comes from. DeGeorge syndrome is thymic, parathyroid, and cardiac defects. Velocardiofacial syndrome is palate, facial, cardiac defects. It's in the name. Catch-22. So that is cardiac defects, abnormal facies, thymic hypoplasia, which leads to T cell deficiency, cleft palate, and hypocalcemia secondary to parathyroid aplasia or DITM. That's cardiac defect for conotruncal abnormalities. Like, okay, for example, tetralogy of Fallot, truncus arteriosus. Then you have adenovirus. Thymic hypoplasia leads to T cell deficiency. Recurrent viral fungal infection, right? Since you have T cell deficiency, so you're gonna have infection. Cleft palate hypocalcemia secondary to parathyroid hyplasia and tetany. There's a decrease in T cells, PTH, and decrease in calcium. Thymic shadow absent on CXR. So chest X-ray, you won't see it. This is an easy one to spot in a question stem because they will give you some of this, if not all of it, right? They'll tell you that the shadow is not seen that's normally seen in other infants. Uh, they'll tell you that there's decreasing T cells, but B cells are fine. The T cells are being made, but they're immature. It could be that as well, because they mature in thymus, or they, uh, differentiate there. Uh, there's decreasing parathyroid hormone, so that's how you know that, okay, so parathyroids weren't there, thymus isn't there. And if PTH is low, you're going to check if calcium is low, so you're going to get calcium, right? Because PTH is the one that regulates calcium. So if you have this stuff that's not there, then you have thymic aplasia. Interleukin 12, you have decrease in interferon gamma. Because remember what interleukin 12 does, right? It's gonna recruit more of this, and yeah. So CD4 recruits TH with that. Okay, so interleukin 12 receptor deficiency, decrease in Th1 response, autosomal recessive. Decrease in interferon gamma, most common cause of Mendelian susceptibility to microbacterial diseases, or MSMD. The defect is decrease in Th1 response, autosomal recessive, because that's why it recruits interleukin 12. The presentation is going to be disseminated mycobacterial and fungal infections, may present with administration of BCG vaccine. This one is important. Almost every one of these are important. They test you on all of these. But yeah, so this one, you're going to have disseminated mycobacterial. Then you're going to think, okay, is it MAC? Is it something else? But then when they give you, or HIV or something, right? But then they'll give you that fungal infection is also happening. But then they tell you that HIV was negative when they tested for it. Then you're going to think, okay, so then that only leaves one thing, interleukin 12 receptor deficiency. They might even say that the symptoms started happening after administration of BCG vaccine. They might not give you this, interferon gamma. But if they do, then interferon gamma always goes with interleukin 12, right? So autosomal dominant hyperimmunoglobulin E syndrome, or Job syndrome. Job syndrome is very easy to identify and classic. It has a classic presentation because it has retained baby teeth, and most of the time they tell you that. But if they don't, they will give you this. There's increase in IgE and there's increase in eosinophils. Okay. What's the defect? The defect is deficiency of Th17 cells due to STAT3 mutation. Okay, so Th17 that used to be induces that. Okay. So deficiency of Th17 cells due to STAT3 mutation, which leads to impaired recruitment of neutrophils to sites of infection. So you're going to have abscesses, but they're not going to be warm, they're going to be cold. So if the abscess is cold, it's going to be this, because nothing else does that. They might just give you baby teeth in an adult. That's also Job syndrome. There's coarse facies, dermatologic problems, eczema. There's increasing IgE. So increasing IgE, retained baby teeth, and cold staphylococcal abscess or just cold abscess are like the buzzword for Job. Bone fractures form from minor trauma. That's not going to be helped by itself because it happens in osteogenic imperfecta as well. Increase in IgE and increase in eosinophilisis. Hyper IgE syndrome, also known as Job syndrome. Then chronic mucocutaneous candidiasis. Here you have okay. The finding is absent in vitro T cell. Okay, so absent in vitro T cell proliferation in response to Candida antigen. There's absent cutaneous reaction to Candida antigens as well. Okay. Sorry, I'm yawning now. Okay. We're doing defect for chronic mucocutaneous candidiasis. The defect is T cell dysfunction, impaired cell-mediated immunity against Candida species. Classic form caused by defects in AR. Right, we know about that. We'll just go back and look at it. Okay, so what was there? It was autoimmune regulator. So tissue-restricted self-antigens are expressed in thymus due to action of autoimmune regulator. Deficiency leads to autoimmune polyendocrine syndrome 1. And here you have it. Chronic mucocutaneous candidiasis, hypoparathyroidism, adrenal insufficiency, and recurrent Candida infection. Okay. So what's the presentation going to be? It's just going to be persistent non-invasive Candida albicans, infection of the skin and mucous membrane. Okay. I'm just looking at my notes. Okay, I'm just going to look at this while I read out my notes. So here you have decreased Ig, even going for all of them. Here you have normal IgG and IgM, but decreased IgA. Here you have decreased Ig, go in and all, an increase. You'll have increase in B cells for this, but decrease in plasma cells because it can't differentiate. So you have a lot of B cells for this one, just not plasma cells. And you don't have plasma cells, so you won't have IgG. For thymic aplasia, there's decrease in T cells, decrease in PTH, and decrease in calcium. And you get viral and fungal infection in this. Sorry. For interleukin 12, you have decrease in Th1, decrease in interferon gamma, and infections, you have TB and fungal for this. In job, it's just like, okay, how do you remember that, right? So it's like, yeah, just retain baby teeth is good enough. Um, and cold abscess, okay. And chronic, I don't have anything for this. Cool. Chronic mucocutaneous candida, it's going to be present non-invasive candida albicans, infection of skin, and mucous cutaneous. So how would you know that this is not HIV or something else if they give you? Okay, cool. That's recurrent thrush, diaper rash, and esophagitis in chronic granulomatous disease. Okay. Also, absent in vitro. Also, I think in the other ones, chronic granulomatous disease, uh, the Candida goes deeper, right? Whereas this one is only on the skin. It doesn't go deeper. Or in HIV, I guess. It's something like that. Okay. Sorry, did you say chronic granulomatous disease? Okay. Immunodeficiency, B and T cell disorders. This is SCID. Uh, we went over this yesterday. Several types, including defective interleukin-2R gamma chains. Most common, X-linked recessive, adenosine deaminase deficiency, autosomal recessive, RAG mutation, which leads to VDJ recombination defect, right? Uh, so you're gonna remember this because that's what we learned in the other one, but they usually ask about this one because that's the most common, X-linked recessive. So in SCID, the findings are decreased T cell receptor excision circles, decrease in. Okay, so now these diseases, they have disorder including both of them. So decrease in T cell receptor excision circles, part of newborn screening for SCID, absence of thymic shadow or chest X-ray, germinal centers, lymph node biopsy, and T cell flow cytometry. Here you have failure to thrive, chronic diarrhea and thrush, recurrent viral, bacterial, fungal, and protozoal infection. Okay, so recurrent viral. So you have all kinds of infection, basically, that's what it's saying. Because, everything is gone. You have none of these. So the defect, again, it's including defective interleukin 2R. That's important because that's what they will test you on. Most common is X-linked recessive. They might just give you all this, that the person has all kinds of infection. Then you know it's SCID, but then they'll ask you what type of inheritance is that. You're going to think of this. Click on this because that's the most common. Uh, they give you both actually in the answer, and they just tell you that, okay, so what is more likely way of this inheritance? So it's going to be this because it's most common. Okay. Partner screening for SCID and absence. So this is also going to be part of the presentation. German centers and T cells. Okay, cool. Next. Ataxia telangiectasia. Defect in this is ATM gene, so failure to detect DNA damage. This causes failure to halt progression of cell cycle, so it leads to mutations accumulate and autosomal recessive. That is okay. sorry, increase in AFP, but you have decreased IgA, IgG, and IgE each because it's sensitive to radiation, so you can think of it that way. Because radiation ages your skin, and this is something to do with skin. So IgA, IgE, IgG, and IgE. Oh, nothing. Okay. So again, IgA, IgG, and IgE they decrease, uh, and AFP increases. Lymphatic power. Okay, we have 10 minutes. Okay. Uh, I think we'll finish. Uh, lymphopenia, cerebellar atrophy. Cerebellar atrophy, increased risk of lymphoma and leukemia. Here the presentation is going to be cerebellar defects, that's ataxia, spiroangiomas, so that's your skin. That's why you remember it this way for age, telangiectasia, IgA deficiency here as well. So you have three things. You have ataxia, uh, they walk different, their skin different, and they eat different because IgA deficiency. Increase sensitivity to radiation, limit X-ray exposure. Okay. The defect is ATM gene. It fails to detect damage, so it's not gonna be able to halt progression of cell cycle. Hyper IgM is similar to IgE, but here since the defect is most commonly due to defective CDL, that's the one on the T cells, right? So on the Th cells, leads to class switching defect, X-linked recessive. Uh, since there is no class switching, you will have a lot of IgM, but you won't have anything else. You might have IgD because they come with that stock, but it's not going to convert to IgG or A or E, right? Your D is going to be normal. So you have normal or increased IgM, but decrease IgG, IgA, IgE. In the question stem, they might just give you that there's a lot of uh, globin, but there's protein, which is globin, but then they have a lot of infection, right? So you're gonna think, okay, so what kind of infection? Because this one here, they have cold abscesses, but not infection. So it only leaves that and this. Okay. Uh, okay. So severe pyogenic infection earlier in life, opportunistic infection with pneumocystis, and cryptosporidium and CMV. Right. This one is pretty easy to figure out. But what you need to remember is that why this happens. It's because there's defect in CD40L on T cells. That's the important part. Just with this, if you know the mechanism, you can just come to this conclusion by yourself. For Viscott-Eldridge, water is the acronym for that. Uh, it's X-linked as well. So it's a mutation in WAS gene. So W is for WAS. Leukocytes and platelets unable to recognize actin cytoskeleton. It leads to defective antigen presentation. It's X-linked recessive. Okay, so you have defect in WAS gene, So what does that do? Leukocyte and platelets are now unable to recognize actin cytoskeleton. So you're going to have defective antigen presentation. Uh, for this, because of this, you're gonna have thrombocytopenia. You're gonna have eczema. You're gonna have recurrent pyogenic infections. Okay. A is for antigen presenting cells. So they have given it, but if you just think of it that way, W is for Wasp gene. A is for antigen presenting cells, because that's where the defect is, right? Defective antigen presenting cells. And then T is for thrombocytopenia, eczema, and recurrent infection. There's increased risk of autoimmune disease and malignancy. Uh, and the lab findings are going to be decrease to normal IgG and IgM, uh, IgE and IgA. This is not going to be helpful. What is going to be helpful is they're going to give you that the person has rash, platelet count is high, and the person suffers from recurrent infections. So if you have all these three, then uh, jackpot. Um, phagocyte dysfunction. LED is the easiest one to figure out because the buzzword is late separation of umbilical cord. They give you that, it's only going to be this. There's nothing else that it can be. Okay. Uh, you're going to have increase in neutrophils in blood, but absence of neutrophils at infection sites. So you're going to have impaired wound healing. This also happens in corticosteroid administration. Uh, you have neutrophils, but they don't go to the infection site. That's why corticosteroids reduce inflammation. It's not that it causes neutropenia. It actually causes neutrophilia, but uh, it decreases that. And because of that, since it doesn't go to those sites, that's why corticosteroid then end up giving you infections and stuff. It leads to infections. So defect is in LFA 1-1 integrin or CD18 protein on phagocytes, impaired migration, and chemotaxis. How much time do we have? Not sure. Okay, how about this? We'll do this in the next one. I'll just make a new one because I want to go over the process of leukocyte adhesion. So let's do that. So I'll just read that again. In SCID, cladribine or cladribine is a ADA inhibitor. It is given in hairy cell leukemia, which is a lymphocyte-derived cancer. Back to LED. For LED, we have this. You have margination, integrin, silated glycoprotein. Okay. Hemoconcentration and decreased wall shear stress. Okay. So these are the steps. First, you have margination. So that's just, them rubbing against the wall, causing the whatever, going next to rolling, basically. Okay. So then here you have P-selectin and E-selectin. Then you have activation, conformational change to high affinity. Then you have tight adhesion. So you have more than two or whatever. Like the more you have, the tighter the adhesion is. And then you have transmigration, right? And this is called PCAN1. Here, the cytokines induce endothelial expression of selectin. So the inflamed interstitial tissue is going to cause the cytokines to be released, causing, the process of adhesion to happen. And here we have chemokines lead to integrin activation. Okay, so this is integrin ligand ICANN 1. They test you about this. This is called transmigration. It involves PCAM1. So you have lead 2, which is impaired fucosylation of silated carbohydrate ligands, prevents selectin binding. In lead 3, impaired cytokine signaling prevents integrin activation, and in lead 1, absence of CD18 prevents formation of functional beta-2 integrin. So this is the one that we're talking about right now. Right, so defect in LFA1 integrin. So that's this integrin beta-2, this one, okay. So LFA1 integrin CD18 protein are on phagocytes, impaired migration and chemotaxis, autosomal recessive. The lab findings are going to be increased neutrophils in blood, absence of neutrophils at infection sites, and impaired wound healing. I feel like I'm having deja vu right now, but yeah, okay. So the buzzword is right here: late separation, more than 30 days of umbilical cord, absent pus, dysfunctional neutrophils leads to recurrent skin and mucosal bacterial infections. You have Shidiak-Higashi syndrome right here. Uh, defect. So Shidiak-Higashi syndrome. It also has a mnemonic. It's LMNOP. So I'll just write that out. It's right here, anyways. But so L is for list gene defect. Then you have micro. Okay, so L is also for lymphohistiocytosis. M is for microtubule dysfunction. Then you have N for neurologic symptoms. You have O in phagolysosome, and you have P for pancytopenia. For Shidiak-Higashi syndrome. Okay, so defect in lysosomal trafficking regulator gene, microtubule dysfunction in phagolysosome, lysosome fusion, autosomal recessive. These are the things. Progressive neurodegeneration, lymphohistiocytosis, albinism, partial, recurrent pyogenic infection, and peripheral neuropathy. So they'll give you this stuff, and they'll give you that the phagolysosomes are like huge. The person has neurologic symptoms. There's pancytopenia. and something's wrong with microtubules. If not, then they'll ask you about this. They'll test you about this, but vice versa, basically, right? So giant granules in granulocytes and platelets, pancytopenia, and mild coagulation defects. Once you start doing the questions on UWorld for these, you'll know how to point them out. Then you have chronic granulomatous disease, uh, like the person said in the last one. You have diaper rash in this. Uh, Defect of NADPH oxidase, decreased reactive oxygen species, uh, superoxide, for example, and decrease in respiratory burst and neutrophils. X-linked from X-linked form is the most common one. Decreased susceptibility to catalase positive organism and recurrent infection and granulomas. When you have recurrent infections and granulomas, you should always think of even just granulomas. You should first think of either this or TB. But when you have recurrent infection, it's going to be this. And they might even tell you that the infection is by bacteria that has catalase in them or something like that, right? Abnormal uh, hydrorhodamine test, so flow symmetry test, decrease in green fluorescence. And there's nitro blue tetrazolium dye reduction test. They actually test obsolete, so fails to turn blue. They actually test you for this one as well now. They used to just test you on this, but now they test you on this as well. Okay, so okay, that's okay. So for this one, dihydro uh, rhodamine, if the test is positive, the way you know it's positive is there's no color or fluorescence. Uh, if it's negative, there's no disease. In positive, there is disease, right? So in negative, there's no disease. And you'll see color or fluorescence. Okay. So abnormal test, that's what they're saying. The abnormal test is when there's decrease in fluorescence or decrease in color or no color. That gives you a positive for disease. Okay. Uh, in nitro blue dye reduction test, uh, obsolete or fails to turn blue. Okay, so normally it would turn blue, but if it's positive, then it fails to turn blue basically. So in both of them, positive test is when you have no color. Correct me if I'm wrong, guys. Yeah. Mm. So yeah, granulomas, recurrent disease, and increased susceptibility to catalase positive. Yeah. So we're done with immunodeficiencies. We got through it. Cool. How much left? We're at 116. Oh, 4 more pages left. Okay. Immunodeficiencies. So for these, when thinking of T cells, it's always going to be about viruses, right? Uh, Bacteria does cause sepsis, but that's more about when you have decreased B cells. When you have decreased T cells, you can have sepsis, but majority of the time you're going to have CMV or EBV or JC virus. JC virus is pretty special because it also has a classic presentation in the head. VZV, JC virus. I'm skipping on what it's called. It's like poly something something. It's when you see multiple lesions in the brain. Let me just search it up. Progressive multifocal leukoencephalopathy. That's what it's called. Progressive multifocal leuko. Okay, so what does it look like? That's what it looks like. Sorry. So you have multiple lesions right there, and since it's multiple, it's in the name. Progressive multifocal, right? Anyways, okay. So you have varicella zoster virus, herpes 3, type 3, chronic infection with respiratory and GI viruses. Okay, and you can have fungal infection like Candida or PCP or Cryptococcus. Okay, you have decreased B cells. When you have decreased B cell, you don't have your plasma cells and stuff. So you're gonna have infection encapsulated ones. This is the best one mnemonic for that. It's please shine my skis. P is for Pseudomonas aeruginosa. S is for Streptococcus pneumoniae. H is for H. influenza type B. Uh, N is for Neisseria meningitidis. E is for E. coli. S is for Salmonella. K is for Klebsiella. Pneumonia group and group B Streptococcus for S, right? For viruses, you'll have enteroviral encephalitis, poliovirus, live vaccine contraindicated. And there's fungi and parasites, you have GI, GRDSs, or no IgA. Uh, None of this has really helped me answer any questions besides just this mnemonic for encapsulated bacteria. I don't think they really test you on what happens with this, but basically B is for bacteria, right? So that's the easy one to remember. Decrease in granulocytes. Some bacteria produce no serious granules. Staphylococcus, Burkholderia cepacia, Pseudomonas aeruginosa, Nocardia, and Serratia. Uh, you won't have any viruses because of these. And for fungal, Candida, aspergillosis, and mucormycosis. If you have decreased complement, then it's all the encapsulated ones. But species with early complement deficiencies, right? Encapsulated species with early complement deficiencies. And Neisseria is a special one because that's the one they always go after when they're talking about this. Neisseria with late complements or C5 to C9 deficiencies. That's it. That's the most important thing they'll test you on. That and you should know which ones are encapsulated. No, B cell deficiencies tend to produce recurrent bacterial infections, whereas T cell deficiencies produce more fungal and viral infection. Transplant rejection. Okay. I actually have a note on this, so let me just read from that. I'll send it to my laptop. transplant rejection. Uh, Hyperacute, it's going to be within minutes. Pre-existing recipient antibodies react to donor antigen type 2 hypersensitive reaction. Activate complement. Uh, Features are widespread thrombosis of graft vessel, arrow within glomerulus. Okay, so that thing right there. Ischemia and fibrinoid necrosis, and graft must be removed. Okay, so the buzzword here is going to be vessel thrombosis. Uh, that's going to be the buzzword. The mnemonic for this is hyper children eat Tic Tacs. This is from Dirty Medicine. All these, right? So hyper because it's fast. Tic Tacs because they look like antibody light chain, right? If you put two Tic Tacs together like that. And it's type 2, so two T's is type 2 hypersensitivity reaction. You have to remember that. Uh, what it is. These ones are T cell mediated anyway, so there's the only one that's going to be uh, type 2, like humoral mediated hypersensitivity reaction. Okay. T is for thrombosis as well, and you get vessel thrombosis. This is going to be the buzzword. Widespread thrombosis of graft vessels. So it's going to be the system. I mean, question stem is going to be like a surgeon was attaching an artery, and then during the surgery, after a while, there was thrombus forming or something like that. So what's happening is going to be because of this hyperacute transplant rejection. So the graft now has to be removed. You will see ischemia and fibrinoid necrosis as well. So if they ask you for that, you have acute now. This happens from weeks to months. Okay, this is going to be T cell mediated. Uh, Weeks to months. So cellular CD8 is that cytotoxic T cell and or CD4 T cell activated against donor MHCs. This is type 4 hypersensitivity reaction. So that is, cell mediated. Humoral similar to hyperacute, except antibodies develop after transplant. So this is both humoral and cell mediated then. It's associated with C4D deposition. Okay. Here the buzzword is going to be interstitial lymphocytic infiltrates. They will flat out say this. There will be vasculitis of graft vessels with dense interstitial lymphocytic infiltrates. Right. That's just a way of saying lymphocytes are in somewhere in there. But don't confuse that, because if they say graft vessel and they see stuff in there, you're going to think, oh, vessel is thrombus. But it's not thrombosis. It's not hyperacute, it's acute. And it happens from week to months. This thing is usually going to happen during the surgery, more than likely. This one happens after the surgery is done. And it's going to be both. So the mnemonic for this is weak, rotting teeth that requires medication. Weak because it takes a week. Rotting because of vasculitis. Teeth will tell you it's T cell, cellular immunity. That require medication. Medication is you prevent it with immunosuppressants. Right? So weak, rotting teeth that require medication. That's from Dirty as well. Chronic is that. Okay. So it takes months to years. Okay. again, CD4 T cell response to recipient antigen presenting cells presenting donor peptides, including allogenic MHC. See, these two are overlapping because this beats 2 months and this months 2 years. So, and this one varies. So all of these actually, you know, overlap. So this is not going to be that helpful. It's just going to be helpful to, uh, differential this out of the way. Okay, so both cellular and humoral components are on this. Type 2 and type 4 hypersensitivity. Sorry. Recipient T cells react and secrete cytokines that leads to proliferation of vascular smooth muscle, parenchymal atrophy, interstitial fibrosis, dominated by arteriosclerosis. All of this is not useful at all. What is right here. So they're going to give you something like this, or they're going to ask you what is it, right? And then they're going to ask you what kind of reaction is this, and it's both type 2 and 4. So they're going to give you chronic allograft nephropathy, or bronchiolitis obliterans, or accelerated atherosclerosis, or and vanishing bile duct syndrome. They give you at least one of these. I've seen this one. I've seen this one. This one is not really that helpful. And you have, okay. So the mnemonic for this is months later they have 24 cavities. Months because it's months. 24 because it's type 2 and 4. And cavities, K for kidney injury. A is for accelerated atherosclerosis, or atherosclerosis. B is for vanishing bile duct. I is for interstitial fibrosis. Okay. So when they give you interstitial fibrosis, again, don't confuse it with interstitial lymphocytic infiltrate. You're going to see vessel, you might think these two. If you see interstitial, you're going to think these two. But interstitial fibrosis is in chronic because it takes a long time to, cause fibrosis. Because fibrosis, it's a scarring of something, right? T is T cell cytokine production. Y for yucky lung, that's your bronchiolitis obliterans, right? And yeah, that's it. Okay. And then you have the easy one. Most likely this is what it's going to be 80% of the time. Graft versus host disease. It's very easy to figure out. Time varies. A grafted immunocompetent T cell proliferates in the immunocompromised host and rejects host cells with foreign protein. Severe organ dysfunction. This is type 4 hypersensitivity reaction, not humoral at all. So only two that are not humoral. It's graft versus host and hyperacute. Wait, never mind. Okay, this is the only one that's not humoral. That was type 2. So there's the only one that's only type 4. The buzzword here is maculopapular rash. They'll have jaundice and they'll have hyperosplenomegaly. They might give you diarrhea, but that's too late to figure out. It's graft versus host. So they'll give you these three or at least two of these. And most likely this is going to be included, maculopapular rash. So if someone is having a transplant done or had transplant done and they give you maculopapular rash, it's going to be this. Just click this. Jaundice, diarrhea, hyperosplenomegaly, usually in bone marrow and liver transplants, rich in lymphocytes, potentially beneficial in bone marrow transplant for leukemia, right? In leukemia, if you do bone marrow. Uh, it's pretty good, but so this would turn into a good thing then. For patients who are immunocompromised, irradiate blood products prior to transfusion to prevent graft versus host disease. I don't think you really need a mnemonic for this, but it's you never know when their teeth will get big, yellow, and rashy. So never know because it's variable time. Teeth because of most common bone and bone marrow. Most common bone. Gotcha. It's just bone. Most common bone. So in bone and bone marrow, kind of like that. Big because liver is big, hepatosplenomegaly. Yellow because of jaundice, and rashy because of maculopapular rash. Okay, uh, so now I'll just do a review of that. Hyperacute, type 2 uh, buzzword, vessel thrombosis. Acute, oh, and this is hyper children eat Tic Tacs. TT for thrombosis, type 2, they look like silver antibodies, so that also tells you it's type 2. Hyper because it's fast. Then you have acute, weak rotting teeth that require medication. You prevent it with immunosuppressant. Teeth because it's T cell. Rotting because it's vasculitis. That's the buzzword. Interstitial lymphocytic infiltrate. And weak because it takes around a week. Uh, in the question set, they usually follow this. This is going to be during the surgery. This is going to be in weeks. This is going to be in months. And this one is just, you have either jaundice or something and a rash, then you know it's this. For acute, it's going to be, yeah, we did that. Chronic. Months later, they have 24 cavities. Months, they have 24 because it's type 2 and 4. Cavities, kidney injury, accelerated atherosclerosis, vanishing bile duct, interstitial fibrosis, T cell cytokine production, yucky lung. Right. Now we have graft versus host disease. It's you never know because it's variable in time. When their teeth for bone. So in most common bone marrow transplant. Will get big, splenomegaly, hepatosplenomegaly. Yellow is jaundice, and rashy is maculopapular rash. Type. Okay, so this is just because it was getting confusing when I was doing it, so I just wrote it out. What allograft is, what isograft is, autograft, isograft, allograft, and xenograft is, right? Autograft is self. It means from self to self. Example would be coronary artery bypass. Uh, okay, so leg vein is used to replace coronary vessel. So that would be autograft. For isograft, uh, it's equal, synthetic, uh, or syngenic. Okay, from genetically identical person to self. So monozygotic twin transplant. That's isograft. Allograft is allo is alien, so allograft or alien or stranger. Other or different. Okay, so that's your from genetically different person to self. Sorry, I'm just surprised that this one's picking up my the way I write stuff. That's pretty cool. Because sometimes even I can't read my own writing. From genetically different person to self, right? So that would be allograft. Same species though. So kidney transplant from a friend. And then you have xenograft. That's from different species to self. So transplanting pig heart valve into patient. Okay, so we're done with that. Just to look at the photos. A is hyperacute, so that thing right there, that's what is that? It's thrombus, right? That's what it was. That's a thrombus. Yeah. Then you have, oh, it looks like they added stuff to this, at least to this. So we'll read that. B is interstitial lymphocyte infiltrate, and C is dung by arteriosclerosis. Okay, so grafted immunocompetent T cell proliferate in immunocompromised hosts and reject host cells with foreign proteins. That leads to severe organ dysfunction. Yeah. HLA mismatches, most importantly HLA-A, B, and DR antigens, leads to okay, increase of D. Okay, that's nothing. I thought it was something important. And we're done. Now on to pharmacy. 3 pages. Okay, so immunology, immunosuppressants, agents that block lymphocytes activation and proliferation, reduce acute transplant rejection by suppressing cellular immunity, used as prophylaxis, frequently combined to achieve greater efficacy with decrease in toxicity. Chronic suppression increases risk of infection and malignancy. Okay, so that's, you don't want to do it for too long because that will just increase the risk of that and that. Okay, so how do we do this? Okay, um, we'll just look at the drawing here in the diagram here and just do it. We don't want to complicate things, right? So let's get okay, so cyclosporine mechanism is calcineurin, calcineurin inhibitor, binds cyclophilin, blocks T cell activation by preventing interleukin-2 transcription. Oh, okay. Like I have a picture here drawn. It's a cat from Alice in Wonderland. That's how I remember this. But so for cyclo, I drew like 2 circles, and since it's two, it's interleukin-2, and cyclo for that. So calcium is right there. It binds to cyclophilin, right? It blocks T cell activation. So I guess right there. So it blocks that. Uh, yeah. Let me just do that. I'll take a photo of this as well and just send it to you. Okay. It's this thing that I want to see. So interleukin-2 activates mTOR, uh, L-dysleukin. Mechanism of action is activates NK cells to kill tumor cells and venous cell carcinoma. Okay, so you have CNT over here, calcineurin coming in to NFAT. NFAT goes into the nucleus, does this thing, interleukin-2 inhibits this, okay, for intracellular proliferation. Interleukin-2 are rapamycin inhibits this, okay, so NFAT is nuclear factor activated T cell, nuclear factor activated T cell, okay. And NFKB is nuclear factor activated B cell. Okay, so you have calcineurin. Let me get that. I have such a hard time seeing this word. So calcineurin inhibitor binds cyclophilin, blocks T cell activation by preventing interleukin-2 transcription. Right, it's in the nucleus. So indication is psoriasis, rheumatoid arthritis. You're gonna give cyclosporin and that. So that's why it's like a little cycle right there. Rheumatoid arthritis. Uh, so why it's that? Uh, in my head, I just think of it like to avoid getting arthritis, you're gonna exercise or cycling and stuff to avoid pain in the knees. You're gonna cycle. So that's what it is. Psoriasis. It's two like that because or two eyes or whatever. Nephrotoxicity. You have two kidneys. Uh, and it's I don't know why it's a cat. It's just I was bored. But now it's stuck in my head. The gingival hyperplasia happens, so that's where this thing is. It looks like braces on your hand, gums. It has whiskers for hirsutism, and it's Alice in the Wonderland is like trippy, right? So it's neurotoxic. And there's hyperlipidemia that I couldn't work it in, but that's how that is. Okay, so cycle out to as taco bean. Okay, so the other one is since it's IL-2, IL-2 has taco kidney beans there, so like that or something like that. Just remember that it prevents interleukin-2, you know, and what that is. This is where it is, interleukin-2. It's inside the cell. Normally, we know what interleukin-2 does, right? It's hot T-bone steak. So the T is interleukin-2. It stimulates interleukin-2. Okay. We spent enough time on this, so you shouldn't forget that now. Note says both calcineurin inhibitor are highly nephrotoxic, especially in higher doses or in patients with decreased renal function. Now we have tacrolimus. Uh, that's this thing right here. Calcineurin inhibitor binds FK506 binding protein. I think we can go back to the other page. It's more clear here. So calcineurin inhibitor binds FK506 binding protein, blocks T cell activation by preventing interleukin-2 transcription. Okay, it does the same thing, right? Because they both work on inhibit this thing. So naturally, it's going to do the same thing. Indication is immunosuppression after solid organ transplant. This is the thing you would give. Similar to cyclosporin, it increases risk of diabetes and neurotoxicity, but there is no gingival hyperplasia or hirsutism, so no cap for this. Okay, both calcineurin inhibitor are highly nephrotoxic, especially in higher doses or in patients with decreased renal function, because then you have less decreased excretion, and so the drug stays in the system longer time, doing more damage. Okay, so you have FKBP over here with tacrolimus. It inhibits this. This one inhibits this. Uh, NF nuclear factor activated T cells going into here, working with that. Now we are Sir Basil, right? It's Sir Basil's kidney transplant. So sirolimus or rapamycin, uh, it's an mTOR inhibitor, so that's right there, mTOR. It binds to FKBP. Okay, so FKBP plus right there. What? We have 10 minutes. Oh, that sucks. We're almost done. I get rid of this window. Get rid of that too. Okay, so mTOR inhibitor binds FKBP, blocks T cell activation and B cell differentiation by preventing response to interleukin 2. Basilizumab, right? That's monoclonal antibody. It blocks interleukin 2 receptor right here. So you have basal right there. You have sirolimus right here. They both work to inhibit mTOR, right? No, this one inhibits mTOR, but this one goes to it. So it just inhibits the receptor itself. Okay. So yeah, we have proliferation of genes of that. Okay. So now we have pancytopenia. Pancytopenia, insulin resistance, hyperlipidemia. It's not nephrotoxic, so that's why this is safe to give in kidney transplant. But any other transplant, this is the one that they give anyways, after solid organ transplant at least. You have edema, hypertension, and tremor in basal. They won't test you on that. What they will test you on is this stuff. So you need to know that sirolimus inhibits mTOR directly. This one inhibits mTOR passively because it inhibits the interleukin 2 receptor, which goes on to mTOR to act on this. Okay, kidney survives synergistic with cyclosporin. So you would give this, I guess, with cyclosporin. Also used in drug-eluting stents. They might say that a patient was given a drug after going through kidney transplant. What was he given? One of these drugs will be there. So don't forget, this is not nephrotoxic. This is safe to give in Sir Basil's kidney transplant. In solid organ, you give this tacrolimus. Cyclosporin and tacrolimus, they both act on interleukin 2 transcription factors. Azathioprine is again, no, we haven't done this yet. Okay. Antimetabolite precursor, oh yeah, we have. Antimetabolite precursor of 6-mercaptopurine inhibits lymphocyte proliferation by blocking nucleotide synthesis. Right? So indication here is rheumatoid arthritis because that's what nucleic acid buildup, right? That does that. Uh, Crohn's disease, glomerulonephritis, autoimmune conditions. Toxicity is basically it will cause pancytopenia. Note: 6-MP degrade by xanthine oxidase. Toxicity increases by allopurinol, pronounced as a thiopurine. Mycophenolate is right there. So that was working on PVRP, uh, amidotransferase. If you want to do some blast from the past, we'll do that. Right there. That was the PVRP, aminotransferase, and 6-mercaptopurine, and has been working on that, inhibiting that. So, okay. Mycophenolate and mofetil reversibly inhibits IMP dehydrogenase, preventing purine synthesis and B and T cells. Glucocorticoid sparing agent in rheumatoid disease, GI upset, pancytopenia, hypertension, less nephrotoxic and neurotoxic. Associated with invasive CMV infection, glucocorticoids, uh, we already know what they do. It inhibits NF-kappa B, suppresses both B and T cell functions by decreasing transcription of many cytokines. It also induces T cell apoptosis. Many autoimmune and inflammatory disorders indicated for adrenal insufficiency, asthma, CLL, that's chronic lymphoid leukemia, non-Hodgkin's lymphoma. Non-Hodgkin's is the one that spreads throughout the body, I think. Cushing syndrome, osteoporosis, hyperglycemia, diabetes, uh, amenorrhea, adrenocortical atrophy, peptic ulcer, psychosis, cataract, avascular necrosis, femoral health. So this is pretty severe, but it's glucocorticoids are, you know, pretty popular, but you shouldn't use it for a long time. Neither that. Notes: demargination of WBCs cause artificial leukocytosis. That's what I was talking about earlier when we were doing the Tang. Okay, I'm not gonna spend time looking for it, but yeah. So artificial leukocytosis, they do cause increase in it because it causes detachment into the bloodstream, but then they don't go to where they're needed. So that's why uh, corticosteroids, stop them from going to the place where neutrophils are needed. So that's why it's artificial leukocytosis. It's not useful, and that's why you have like all of these. Like you also have infections because of that, and vasculitis and stuff. Uh, Adrenal insufficiency may develop if drug is stopped abruptly after chronic use. Because when you give glucocorticoids, what happens to the thing that's making glucocorticoids? It's going to shrink. So then when you stop giving it right away, your body can't handle that amount of load because it's already shrunken. So, you know, don't stop it like that. Recombinant cytokines and clinical uses. Yeah, we're not going to make it. Yeah, I'll just take a break and actually, we'll just continue. I'll just make a new link and just come back. Okay. Cytokines and clinical uses. So we're going to read about cytokines. It's the agents and clinical uses for them. Uh, Bone marrow stimulation, erythropoietin, epoetin alpha, EPO analog. Anemia, especially in you use it in renal failure, because EPO normally gets regulated by kidneys, but in like chronic kidney disease or renal failure, you don't have that kind of regulation, so you give artificial EPO or its analog, right? It's also associated with increased risk of hypertension and thromboembolic events. Why? Because when you give EPO, what does it do? It stimulates your bone marrow to make more cells, right? Or erythrocytes. So when you have more erythrocytes, your plasma volume gets increased as well, which causes hypertension. Why does it do that? Because normally EPO would be regulated by kidney, but it's not, right? So even after you have the desired amount or you know, desired amount of RBCs or erythrocytes, it's not going to stop. It's going to continue stimulating the bone marrow. So that's why it increases the risk. Colony stimulating factors, filgrastim or G colony stimulating factor, sargramostim or GM-CSF. When do you give colony stimulating factor? You give it when during leukopenia, because you need more of that and you don't have any. Recovery of granulocytes and monocyte counts. Thrombopoietin, they stimulate platelet formation. These are your romiplostim or TPO analog. Eltrombopag, think Eltrombopag if you want to. TPO receptor and agonist. None of this help. Just remember, when you see this or romiplastin, it's about this. This one is easy to remember. This one is not really that easy. It's kind of stretching it. GM. Even this has GM in it, but okay. Autoimmune thrombocytopenia is where you would give thrombopoietin and platelet stimulator as a platelet stimulator. Okay. There are two more that you should know about. I'll write it out here. Rituximab and belimumab. Is it given here? Yeah, so you should know about these two. I'll just talk about it. So rituximab, it is a IgG monoclonal antibody against CD20. So it's against CD20. Okay, now they test you on that. It's very important. But it's pretty easy. Just think of a girl named Ritu who's a 20-year-old girl, right? So then Ritu is 20 years old, so that helps. So what does it do? It depletes B cell population, because remember CD20 is on B cell, 19, 20, 21, right? So it depletes B cell population. Belimumab also inhibits B cell. But they don't mention through which CD marker. Then also you also need to know about abatacept. Second. No. Yeah, so this thing blocks CD28 receptors on cytotoxic T cell. So it prevents T cell costimulatory or signal, or known as causing energy. So it blocks CD28 receptor on cytotoxic T cell, causing energy. Why would you want that? It's so that it prevents or reduces inflammation. That's why. Okay. Now we do immunotherapy. Interleukin-2 also known as aldesleukin. Okay. It's used for renal cell carcinoma and metastatic melanoma. Interferon alpha and beta, we know they're used for right here. What it does is it halts protein synthesis, such as RNase and protein kinase R. These only activate in presence of double-stranded RNA, which only forms in infected cells as a result of viral replication. Majorly, this is the MOA, right? So, interferon alpha is used in chronic hepatitis C, but it's not preferred, and B, and in renal cell carcinoma. Interferon beta is used in multiple sclerosis. Gamma is used to, in chronic granulomatous disease, because if you can't kill them, block them. Therapeutic antibodies. Agents target clinical user notes. Autoimmune disease therapy, adalimumab and infliximab. Soluble TNF-alpha, inflammatory bowel disease, rheumatoid arthritis, ankylosing spondylitis, and cirrhosis. Right? Notes are pre-treatment screening, CMV, EBV, HBV, HCV, TB, VZV, or varicella-zoster virus due to risk of reactivation. Etanercept is a important one that you should know about this drug. It is a decoy tumor necrosis factor alpha receptor and not a monoclonal antibody. Okay, so etanercept intercepts, basically. It's a decoy TNF alpha receptor. So I think of it like, okay, so Eda is watching Netflix, something that's, the Ninja Turtles or something, because there was a turtle named Franklin, so the Ninja Turtles, and she got intercepted by another Ninja Turtle or something like that. It just, remember that, because they ask you about these, so remember it however you want to, however it works with you in your head. It's used for IBD. You'll see it in GIT again. Rheumatoid arthritis and ankylosing spondylitis and psoriasis. Okay, then you have eculizumab. It's a complement protein C5. It's used in paroxysmal nocturnal hemoglobinuria. That's the one with the complements attacking self, right? With CD55 and CD59, Merrill and DAF. Right? It's associated with increased risk of meningococcal infection. So that was eculizumab. It's equal to C5. Okay. Guselkumab. That's interleukin 23. It's used for psoriasis. I haven't come across any of these. I have come across these two. This one. Not this or this. I come across this one. That's it. And the ones I told you about here. Okay, but we'll go over it. Ixekizumab, secukinizumab, numab, or whatever. Interleukin 17A. Again, psoriasis, psoriatic arthritis. Natalizumab, alpha-4 integrin, multiple sclerosis, Crohn's disease. A4 integrin, WBC adhesion, risk of PML in patients with JC virus. Okay, there you go. they given it here. That's why JC is important. And you give this nelizumab in JC. Natalie believes in JC, right? So do many people. Okay. USTEKI, so that's ustekinumab. Interleukin 12, interleukin 23, psoriasis, psoriatic arthritis, and vedolizumab. That's alpha 4 integrin used for IBD, gut specific anti integrin, preventing migration of leukocytes to gastrointestinal tract. Other applications for monoclonal antibodies: denosumab, rancol. They ask about this one. Osteoporosis, inhibits osteoclast maturation, mimics osteoprotegrin. They help make dense bones. So Dino makes dense bones. And then you had imizumab, factor 9A and 10, hemophilia A, bispecific, mimics factor 8, omalizumab, immunoglobulin E. They ask about this one as well, but I think they ask about it in asthma or asthma. Refractory allergic asthma prevents immunoglobulin E binding to FcRn. And pelvizumab. You think, well, my neighbor had a daughter, her name was Pelvi, and she was little, and she suffered from this. So it works out for you guys. So remember that way. RSVF protein, respiratory syncytial virus, I think. I forget the full form for this. Let's look it up. Yeah, respiratory syncytial virus. Prophylaxis for high-risk infants. So pelvizumab virus. And that's it. You're done.